Sir, is the session visible in the screen?
Visible. Visible.
Okay. So, good morning, everyone, and welcome to the two-day online workshop of National Institute of Rural Development and Panchayati Raj on providing telemedicine facilities in rural areas. As you know, the Ministry of Rural Development has been thinking for some time to deal with the health access issues in the villages of India. And one of the major reason of health shock, or one of the major reason why people move from the vulnerability zone to the poverty zone, has been found to be major health shocks and health accessibility problems. So there has been a lot of talk on how to use technology to kind of overcome the health access issues, whether we can reach the remote areas in an affordable manner, in an easy manner with the new kind of technologies coming up. So telemedicine has been coming up as a very effective way to reach communities in the remotest of the areas. So to understand the nuances of how you are providing telemedicines, what are your experiences, and what are the possibilities and scopes that we have to coordinate with the RD ministry with you, we have called for this workshop. So how we have planned this workshop is that there are some experts with us who will be talking about the telemedicine facilities, who will be talking about the case studies, their own experiences with telemedicine use in the corporate hospitals, etc. And we will also have a very open interaction with you as to what you think or what are your experiences on telemedicine or in general health access with technology in the rural areas. So there will be interactions as well as the sessions. So we really request you to stay with us for the next 2 days and to be with us with all the sessions so that we can have an open discussion later as well. So if you see in the screen, what you are seeing is the session plan, and this is indicative session plan. The timing may be a little flexible depending on how the speakers take it up. Some of it is a panel discussion as well. But to give you an indication of how the next 2 days are planned, first we will have a session from Dr. Pankaj Mathur from University of Arkansas for Medical Sciences. He will be talking about telemedicine as an emerging solution for health access, and he will be taking you to the overview of what telemedicine really is and how it works, etc. Then we have a panel discussion on telemedicine for rural health access, and then panel we have three distinguished panelists. First is Dr. Karunakar Reddy, who is the managing trustee of Sashodhan Trust. Some of you may know about the trust. It has done a lot of work on telemedicine and health access in rural Telangana. He will be talking about the experience of implementing telemedicine initiative in India's villages. The second panelist is a young doctor from the Department of Basic Medical Sciences, Manipal Academy of Higher Education, Dr. Sambit Dash, who will be taking you through the challenges and solutions to implementing telemedicine. And then we have our distinguished panelist, Dr. K. Ganapathy, who is from Apollo Telemedicine Networking Foundation, is the director, and Apollo Telehealth Services, who will be talking about the remote technology-enabled rural healthcare, a corporate hospital experience over 22 years. After the panel is over, we will have a discussion with you. Dr. Shaktivel will be anchoring the discussion, but we will hear from you what you have to share and what you have gathered from the presentation and what else can we learn from your experiences and your own field level work. The next day, that is tomorrow morning, we have a session with Dr. Murthy Gokula, who is a geriatric specialist from University of Toledo, who will be talking about the implementation of experience of telemedicine in rural India. You can see that the session is starting a little early tomorrow at 9 a.m. because he is also joining from US, just like Dr. Mathur. So we have had to kind of prepone it a little bit so that his timing is adjusted better. Then we will have a group discussion with your group where we will discuss the scope of telemedicine as future rural health, and I'll be dividing you into 2 or 3 groups depending on what kind of discussion we have today. And from the group discussion, we will be documenting the learning of this workshop, and this whole the proceeding of the workshop will be submitted to our ministry as the outcome document. And then we will have a valedictory session. So this is the plan we have for 2 days. It's not very highly packed. As you can see, there is a lot of scope to talk, to interact, to learn from each other, and to kind of, also learn from our experts who will be joining today. So with that, let me close the session here, plan here. And I would now request Dr. Shaktivel to, formally welcome you and give a welcome address. So over to you.
Thank you, Ruchira. Good morning, our distinguished panelists and our participants from various health departments and consultants who are working with the government and also private. And I'm really happy that it's a new area for us. NIRD, we were working, we don't work much on health aspects, but we have started looking at it as an important element in rural development. So our management has been very keen, and the ministry is also very keen to initiate certain convergence with the health departments and ministries of the state. So it's an opportunity. We thought we can explore and provide guidance to the ministry. So that's why this workshop is being planned. And telemedicine has been one of the areas. So I think if you look at the urban population is getting the benefit because of the technology connect, but rural areas are still uncovered, like with solutions like Practo and others. City urban population is tapping it to its advantage, but in rural areas we need much more guidance because the diagnostic facilities or supply of medicine or proper support is not available. So it has been always a challenge in ensuring telemedicine. It's not spreading the way it is spreading in the urban areas. And definitely, I see our panelists who work on these aspects. I think it's very important that they have started working on this aspect, and it will be very useful to learn from them and understand what they think could be the solution. So that's why we thought it's a workshop in which we will have certain experienced medical practitioners who are already dealing with it, so that there will be more experience that can be brought into the table, and then it can be formally given to the ministry. So in the meantime, like we had certain discussions with Dr. Karnakar Reddy, who has been closely associated with us. He used to come for the technology park that we run on entrepreneurial activities. So he has been talking to us, and while establishing his trust after coming from the US. And also Dr. Murthy Gokula, we had a very intense discussion on telemedicine possibilities to promote entrepreneurial activities through the women self-help groups. Like they have developed this Health Cube, one of the tools that they've developed, and it was demonstrated here in NIRD during a workshop, and we were very keen to look at it as a potential tool for engaging youth and women in rural areas who can become a health entrepreneur. So we had a lot of discussions, and still we are ready to take off on that particular aspect, but we feel that is also a potential tool that can be supplementing the governmental system which is there in the rural areas, and also it can help diagnose properly in rural areas. At the same time, it can connect a doctor who is away in a city or urban area. So it has the potential. So we thought his experience of his team, which is part of that, developed that, so will be also useful. So in this connection, so I think I don't want to, because the time zones and Dr. Mathur and he has joined from the US, so I don't want to prolong my introductory remarks. So I welcome you all formally, and I thank you for taking out time and coming for our discussions. And I know why it's an important area. So we'll be very happy with all your feedback if we can get, and we can draft a way forward for our ministry in trying to see how it can be converging on telemedicine aspects in rural areas. Thank you. Thank you. And I would like to thank Ruchira and others who have worked to have this workshop today. So I thank you, and I look forward to a very enriching discussions in these 2 days. Thank you, Ruchira. Thank you. So to you.
Thank you, sir. Thank you for this formal introduction. And for our participants, we would like to let you know that this is, I mean, we encourage interactions from you, and there will be times where we will be inviting you for comments and for learning your experiences. So as we have already told you in the email, that please check your net connectivity, your mics, etc. that is ready, so that we can smoothly have the sessions when it comes to interactions. With that being said, there is also another request from us that because these are NIRDPR programs, the NIRDPR programs are all certified. So those of you who are joining here today will receive a certificate. But then we require you to register in the training management portal for certification, and we also seek your feedback on the program. So by the end of today's sessions, we will be sharing a link with you which will take you to the registration portal. I request you to register in the training management portal, and once the program is over, you will get a link to give your feedback. So please register your feedback, and then we will certify your your presence in this program. Now I would request Dr. Mathur, if he is available here, because our introduction session is over and we'll have a detailed introduction with our participants later on in the interaction. So I would request Dr. Mathur to start his presentation. But before I hand over the mic to him, let me formally introduce the speaker, to you. Dr. Pankaj Mathur is joining here today from University of Arkansas Medical Sciences, which is in Little Rock, Arkansas, USA. He is presently a fellow of cardiovascular diseases. Previously, he worked as assistant professor and academic lead internist and was promoted to associate professor at the University of Arkansas in his medical school was from Maulana Azad Medical College, New Delhi, and the post graduation he did from GSVM Medical College in Kanpur. During this time, he worked at IIT Kanpur on a project, the role of telemedicine in screening, diagnosis, and management of ischemic heart disease, and submitted the thesis for MD for the same. He presented this research at Cardiological Society of India Conference in 2006 and Second International Emergency Medicine and Disaster Preparedness Conference in New Delhi in 2006 by American Academy of Emergency Medicine and Society of Emergency Medicine in India, that is SIM. He is a researcher and writes about transformative ideas in healthcare, especially telemedicine and artificial intelligence. He is fascinated about the subject of telemedicine and its potential to transform healthcare in India, and also has written paper on evolving role of telemedicine in healthcare delivery in primary healthcare, which has been cited nearly 40 times in different researches in various journals. He has written about the use of artificial intelligence in cardiovascular diseases, which is again an example of ICT use in healthcare, published in 2020 and has been extensively cited. He is widely published. His several papers we can share with you at some other time, but we would really like to hear from him now and would like to hand over the session to him to talk about telemedicine and his work in this area. Dr. Mathur, it's over to you.
Yeah, thank you very much, Dr. Bhattacharya, for your kind introduction. So let me pull up this. I hope everybody can see my screen. Trying to. Can everybody see my screen? I cannot see my screen, so let me see.
We can't actually. Have you shared the
Okay.
screen, sir?
Yes, let me share the screen. I think that's okay. So I hope it's working now. Can you
No,
see
it's
now?
not visible yet.
Can you see see the screen now?
Yeah, now we can see it, sir.
Okay, so this is opportunity. I think Dr. Bhattacharya emailed me a couple of weeks back, and I said that I would be happy to present this. This is telemedicine is a field that I am really very fascinated about, and it has a really great potential, especially in India, because India is such a vast country. Like it's healthcare for all is as a goal. It needs the input from the information and information technology, and it can really help us all. So this content is presented in this presentation are my personal views, and it does not reflect that of my institution UMS, and it's only for educational and informational purpose only. So starting, we all starting in the morning, it's like this. The brain is a wonderful organ. It starts working, and then it goes to stop. India is a vast country. It is like 1.2 billion people are there. There are no solution, which is one solution for all. So it is kind of difficult to have strategy in place for whole India. But again, it is, there are so many opportunities are there. We should just start somewhere. So in this, for this presentation, we I have made this uh, subheadings: telemedicine, rural healthcare in India. So we'll go over what is telemedicine, what is the history of telemedicine in India, what are the current status of healthcare in India, and then there is a small case study of Tripura, and what is the current status of telemedicine in India, and telemedicine and global health and future implications. So, what is telemedicine? Telemedicine, like a World Health Organization has defined telemedicine as a delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease, and for continuing education for healthcare providers and all the interest of advancing health of individuals and their communities. So, how it is done? Telemedicine can be classified into basically two types. So, store forward or asynchronous type of telemedicine, where there is an exchange of pre recorded data between two or more individuals at different time and places. And then the second one is real time or synchronous, where there is a real time exchange of information between healthcare professionals or a patient and a physician, and for a wide array of clinical services, including disease diagnosis, triage, management, and follow up of diseases. The ICT tool used in telemedicine can be just like low tech tools such as telephones, fax machines, video cameras, or high tech tools like advanced computer or digital imaging, face and requiring like broadband internet connections and satellite support. So there are these two terminologies we need to understand is like telehealth versus telemedicine. Telemedicine is mainly for the curative services, the treatment services, and the telehealth encompasses everything. It is like education in healthcare, health data use, patient education, public health, data research and evaluation, and healthcare related services. So these are the definitions. Telehealth, the use of digital technologies to deliver medical care, education, public health services by connecting multiple users in separate locations, and a broad definition of technology enabled healthcare services. Telemedicine, the use however, the telemedicine is the use of medical information exchanged from one side to another side via electronic communication to improve a patient health status and clinical care from a distance. So that is the main kind of like a difference between telehealth and telemedicine. Telemedicine has like many applications in the field of radiology, cardiology, dermatology, neurology, oncology, and pathology. So now going to the telemedicine history in India. So this telemedicine initially was in 2000. It was initially started, and Dr. APJ Abdul Kalam was also very instrumental um, in um in starting the concept of use of IT in healthcare and to improve the healthcare in India by the use of IT technology. So this is just like a picture, like of him, like opening one of the first telemedicine facilities in Tripura. um, and this was like he was himself involved in starting this pan-African initiative in 2004 to connect India to African countries for telemedicine. So this is kind of like a map, like which uh, shows government players and the private enterprises who are working in the field of telemedicine. ISRO was the pioneer in this field, and it set up 384 rural hospitals, 60 tertiary care centers were set up, and this was all in 2000. And in the northeast, like it was they set up telemedicine application centers, nodal centers in the northeast, and in the private players, Apollo Telemedicine Network is one of the biggest in the country. 125 telemedicine nodal centers are there, and there might be now even more. And then 7 telemedicine specialty centers are there. Narayan Hirtualay is also a big private player in this field. And these are the government institutions, the PGI, Chandigarh, AIMS, SGPGI in Lucknow, CDAC, Mohali, and Department of Information Technology, Government of India. These are the main players in the field of telemedicine in India. And there are like now, because of the mobile health, there are like so many other new players are coming up every day. So ISRO is the main um, um, the provider for the telemedicine in India, and they set up 60 super specialty hospitals, 18 mobile telemedicine units, and 306 rural hospitals were kind of connected by the telemedicine network. And ISRO provided the technological know-how and infrastructure for the telemedicine projects for both Government of India and private sector healthcare players like Apollo hospitals for teleconsultation, disease diagnosis, and management. And ISRO also provided mobile telemedicine units for rural healthcare camps, especially in the field of ophthalmology and community health. Um, so what happened during these were already established in 2000 and 2000 up to 2010 and 2014, and then somehow I think that currently I checked the ISRO website also. I guess because of the lack of funds, or funds were allocated to some different schemes. I think these um, or there are like they said in like 2016 a memorandum of understanding was signed between Ministry of Health and Family Welfare and ISRO, that they would revive the existing telemedicine node in phases. So I guess because of the lack of infrastructure and the financial support, they are like not very functional right now. So this was actually from a paper in 2011. Like there were like so many telemedicine nodes, and these were the like different fundings from ISRO, Department of Information Technology, CDAC. They were working with district hospitals, specialty hospitals in doing all this telemedicine work. This was again geographical distribution of telemedicine nodes. This was in 2011. And this is Apollo Telemedicine Network. This is it's one of the largest in India, and I guess if you see the number wise, it might be one of the largest in the world. And they have 16.5 million teleconsultations across 95 specialties. So then one of the other thing about telemedicine was like how to connect different medical colleges in India for consultative services, and how to share the knowledge across the country. So this was also set up, National Knowledge Network, and I think this is still working. Then we have also set up a national telemedicine portal, and it is organizing several online courses, webinars, and mainly for educational purpose for the medical colleges all over the country. Now, I just wanted to tell briefly about the healthcare in India, so as we know and understand that why it is very important to have a telemedicine in India. So this was the National Health Mission, and these were the like targets which were announced in the National Health Mission to improve the health of everybody in the country. So it was so MMR is the maternal mortality rate, and the target was to less than 1,000 per thousand live births, infant mortality rate to less than 25 per thousand live birth, and um, reduction in the total fertility rate, reduction in the anemia, reducing the mortality and morbidity of the communicable diseases, and lot of like communicable diseases, like how to control them, was under this program. So this is the present annual report from 2021 to 22 from Ministry of Health and Family Welfare. This is our like current status of crude birth rate, crude death rate, total fertility rate, maternal mortality rate, and other stuff. And as we can see from 1950s to now, like, we are making progress. So we are doing good, but is this progress good, or should we do it faster, in a faster way, to elevate the healthcare across the country? That is the question. So this is just to give a perspective from of India with respect to other countries. This is from WHO website, and so India, like, this is just like one of the data point, like, I took out. This is number of under five deaths. So from 1960s to 2020, India has made like a lot of progress from around 44 lakh kids dying of less than 100, less than under 5. It is now like around 7 lakh per year. Most of them are like vaccine preventable diseases which these kids are dying, so which are like easily preventable causes of deaths. So so this is just sorry. So this is just like national immunization statistics from 2005 to 2020-21. We have made a lot of progress. That means previously we have like around 43% of the kids were immunized, and now we have 76.4% kids which are immunized. But still, we in the developed countries, this number is around like 90% or more. So we still have like a lot of progress to be made. This statistics shows how much institutional delivery is there, and again we can see that we have made a lot of progress from 40.9% to 88.6%. So we are making a lot of progress, but still, like, there is still we need to do more. These are other numbers which show that, like, are we need to improve. Like under 5 mortality rate, current status is 36, and we need to reduce it by to 23 by 2025. So this statistic table shows that it is there are like lot of factors are involved in improving the healthcare in particular state or a region. And one of the thing we say is that, like, the access to healthcare, and what is the terrain of that area, or like how is the educational status of that area. So all these things are very important. For example, if we see Madhya Pradesh, like, there is a lot we need to do, like, and all these Madhya Pradesh, Uttar Pradesh, Chhattisgarh, these are not like, the very remotest part where, like, there is not access to healthcare is there. It's just the educational status, beliefs, which I think telemedicine can really help in improvement of the healthcare in these areas. And and then again, we don't have data from northeastern states, but they are actually doing better than the Uttar Pradesh or say Madhya Pradesh from that. And there are, like, there is a presentation, like, in we will see in so then there is this population growth. India is doing better. Population is now getting stabilized. Now it is like 1.64, so it is getting better. So I am just like briefly telling about, like, how or what were the achievements of the national Health Mission or the National Rural Health Mission. And I think now Ayushman Bharat scheme has kind of um, it's kind of like consolidating the sub health centers, primary healthcare centers, and community healthcare centers all over India. So I think they have now named all these centers as Ayushman Bharat Health and Wellness Centers. And they are expanding and strengthening the existing reproductive and child healthcare services, and have now involved communicable disease services, non-communicable disease services, especially of hypertension, diabetes, and three common cancers: oral, breast, and cervical cancers. So this is something new which they are now government of India is like trying to put more emphasis in all the kind of like comprehensive health at the level of CHC or community health center, like as previously it was called. So then we are also thinking that to include mental health, ENT, ophthalmology, oral health, geriatric and palliative healthcare, as well as trauma and health promotion activities like yoga under these schemes. Um, and the other thing which will definitely help, to improve the healthcare will be this. I think to have some kind of like insurance or health coverage for the poor socioeconomic people. So here, so this is a case study, I am presenting about Tripura and how that in spite of being in the very remotest northeast part of the country, how the healthcare indicator in Tripura are very good. So this is the infant mortality rate in Tripura. This is like 21. The average of India is around like 30. Crude death rate is also better than the national average. So all the things are actually better than the national average. So telemedicine actually somehow came to Tripura in 2005. So they set up first telemedicine network in Tripura at the GB Pant Hospital and IGM Hospital in Agartala, and they made few nodal centers in the state of Tripura. And then subsequently second and third telemedicine centers were set up, and with the help of BSNL, Ministry of Communication and Information Technology, and along with WEBL ECS, which is a kind of a public sector undertaking in collaboration with the IIT Kanpur. And they did a lot of good work, and there were around 52,796 patients were treated in 9 years from June 2009 to 2014. And major disciplines covered under this services are like medicine, radiology, orthopedics, pediatrics, gynecology, surgical dermatology. Um, so this was then, and then so by around 2010 or 2000, these were the nodal centers for telemedicine in the state of Tripura. These were the three major referral centers, and the IT support was provided by DIT, Webel Electronics, this communication company of West Bengal, public sector undertaking company, and IIT Kharagpur. So healthcare wise, if we say that they have a lot of healthcare infrastructure, which is not correct, because there is still the total number of sub health center, primary healthcare centers were still less than the target. But somehow these guys are doing making good use of the resources that are available. So, and telemedicine is still very active in Tripura. And I saw this paper, which was just published in 2022, and about teleradiology and the effectiveness of telehealth model in the rural healthcare sector. Basically, what they did in this study, which was carried out in January 2018 to November 2021. And they kind of like involved an alliance between government network of 26 CHC. This is community health centers, district health centers, and sub-district centers and hospitals of Tripura, and teleradiology solution in Bangalore, Karnataka. And over a period of 3 years, they found they interpreted the teleradiology studies, and with a mean turnaround time of 3.19 hours. What this means is that, like, if somebody has done an X-ray in Tripura, the report of that X-ray will be read within 3.19 hour, which is like not bad. Um, and so they concluded that teleradiology has proven to be a value-added service in rural healthcare in remote northeast of India. So they are still doing a good work there in the field of telemedicine. So basically, what I understood is that, like, systems work if they are done properly, and the grassroots workers and the coordination between intergovernmental agencies is the key to success. And training grassroots workers, education, and recognition of their work is very important. So that is why I think Tripura, it's like doing well, because despite the lesser number of resources, they are making like good number of with whatever resources they have, they are able to utilize them very effectively, and using telemedicine or whatever services they are available, they're making use of them. So this thing, COVID-19, like, actually changed a lot of things worldwide and in India also. Ministry of Health and Family Welfare, like, it set up of e-health and telemedicine initiative in, I think in 2020. And now we have a national teleconsultation services. E-Sanjeevani was set up, and around 68 lakh people were served, and, like, a lot of providers, physicians were onboarded. So a lot of work has been now done after this COVID. So this is a E-Sanjeevani is actually a national telemedicine service in India, is delivered via two variants. One is like doctor to doctor telemedicine platform, and another one is doctor to patient telemedicine system. The key feature of eSanjeevani or Ayushman Bharat healthcare wellness center include like MIS based application, comprehensive electronic medical record system, teleconsultation, and video conferencing. So total number of teleconsultation under eSanjeevani was like 116.91 lakhs as of 16. So I think it's a good way to start the telemedicine services nationally. Then there are like a lot of schemes are there to consolidate healthcare in India. Pradhan Mantri Ayushman Bharat Health Infrastructure Scheme was also in launched in the financial year 21-22, and to strengthen the healthcare structure across the country. Basically, what it is doing, like what it wants to do is to target to build a IT enabled disease surveillance system by developing a network of surveillance laboratories at block, district, regional, and national levels in the metropolitan areas, and strengthening health units at the point of entry for effectively detecting, investigating, preventing, and combating public health emergencies and disease outbreaks. So basically, it is a kind of telemedicine, and it is one of the use of telemedicine is to get the disease surveillance system and treatment and all this stuff. So this is kind of like telemedicine, use of telemedicine to strengthen the national health infrastructure. And this is again, if we go to this website, like, we find this health management information system. This is also a portal which gives like a lot of information regarding the healthcare indicators of India. And so this is also a good way to kind of uh, um, for the to understand the discrepancies or disparities in the healthcare indicators of India, and both at the district and the national and the state level. So it's a web-based portal which helps in effective monitoring implementation of various program under National Health Mission. And at present, there are like 2.5 lakh health facilities which are uploading their data and infrastructure report on a monthly basis in this website. And it captures around 400 data elements of service delivery and captures 700 data elements of infrastructure. So these these data entries are like basic reports, and has a national identification number and a local government directory used for unique identification of healthcare facilities at the village and the block level. And then lot of the features of geographic information system are developed and made functional. Basically what it I think what the purpose of this is to develop a kind of at the state level and at the block level and the village level, like what kind of diseases are prevalent in that area, what kind of things or we need to do at that area to improve the healthcare. So I think all that information can be we can get from this health manager information system. And it also supported like COVID portal and interaction of with best practices and public health monitoring and assistant of emergency response unit during Mahakumbh at Haridwar was also done. So, and this is the kind of the website of health management information system, and it has like national health portal also, and all these websites are there to um, which really helps in getting more information about the healthcare in India. And again, this is another initiative which is like telemedicine, because this is a mother and child tracking system and the reproductive and child health portal. So this is the reproductive and child health portal, and this is to facilitate timely delivery of healthcare services to all the pregnant women, lactating mothers, children. And this was, I think, more of a mobile or health initiative, which is like kind of like telemedicine. Uh, and it has been implemented already in the 34 states. And they are sending data to this MCTS, Mother and Child Tracking System portal, and a total of 20.67 crore pregnant women and 17.81 crore children were registered in this portal as of 30th December 2021. So this RCH portal has helped healthcare worker in planning for service delivery and identification for beneficiary due to antenatal checkup, postnatal checkup, and immunization services. Which is these are the things like which are very important to improve the maternal mortality rate, to improve the infant mortality rate, neonatal mortality rate. So I guess these are it's very important to have a look at this RCH portal and see what's going on. And it also helps in identification of high risk pregnant women and tracking of health conditions and assistance during the delivery of pregnant women. And data of child immunization is also helping healthcare worker in generation of work plan for delivery of immunization services. So the another thing which this portal, RCH portal, is it's also capturing the data of beneficiaries from multiple applications. So that is, I think, what is challenging in India now is to how there are like so many applications are there, so many governmental organizations, private sector, they have set up like all these online applications and how to integrate all these applications and get a kind of like a unified data. That is so this, I think, MCTS RCH portal actually captures data of beneficiaries from multiple applications like this eJanma in Karnataka, and Mole is another web-based application, and Kilkari and Mobile Academy. So these are that is very important in telemedicine also, is to get the accurate data. So if we are missing some data, then it will not be of any use. So it's important to capture data from all the beneficiaries which are working in a particular field. So this is Anmol is also a tablet-based application. This is a Government of India scheme also, which powers Anganwadi workers, frontline healthcare workers, in carrying out their day-to-day activity effectively by entering and updating service records of beneficiaries on real and near time or near real time basis. And it is already being used by around 97, almost like 1 lakh Anganwadi workers since inception. So then again, this is the National Health Portal in the Ministry of Health and Family Welfare website. And there are like so many major healthcare initiatives. So these are the healthcare initiatives which are mainly in the field of like education, and there are also online registration system for the outpatient visits are also there. And then in 2020, telemedicine practice guidelines were actually put in place by the Indian Medical Council. So now there are like guidelines that we can have a telemedicine visit by a healthcare professional, a physician, and like they can have like first visit, and all these things are available on the internet now. Now briefly about healthcare in United States, like it's also kind of like challenging everywhere. So US has its own challenges in healthcare about the medical insurance, about the licensing of physician, liability, and the privacy of patients online. All these infrastructure related problems, all the things are there. But these are the kind of like service providers in telehealth in United States. Excuse me. And trends in outpatient care delivery and telemedicine during COVID pandemic actually increased. So this is a paper which was published in JAMA, which is like one of um, the best journals in medicine, and they found that telemedicine televisits number significantly increased, and it has kind of like after the pandemic it has came down a little bit, but it's still like a lot of telemedicine visits are there. So according to McKinsey, this is like a big company of healthcare analytics, and they said that telehealth is a $250 billion uh, healthcare industry. And They said that like there is a lot of funds which are going into the companies which do telehealth, and you can see like how the revenue of all these companies have increased. um, the important thing to see in this paper was that 76% of the people are now saying that they find telemedicine visits very they are now interested in it, and they are like they want like it's like kind of like preferred. So they are interested in. Previously this number was low, and um, and then even from the provider point of view, the physician's point of view, physicians and healthcare practitioners in United States are also keen to do like more telehealth visits, because now it is being reimbursed in United States by the health insurance companies also. So if you see this Center for Medicare and Medicaid, which is kind of like health insurance company, health insurance like a health insurance main health regulatory body in United States, it approved around 80 new services which can be covered by telemedicine. So telemedicine in different field, it has like many applications in the field of cardiovascular medicine. So it can have do the remote medicine, arrhythmias, diabetes management, cardiac rehabilitation, weight loss monitoring and counseling, hypertension management, primary and secondary prevention of heart disease. There are a lot of applications are there. Even in the field of oncology, which is like cancer, the American Society of Clinical Oncology, like Cancer Society, they said like you can also do like new patient consultation, medication prescribing, and management by telemedicine also. Of course, they will need to come to see the physician, get their blood test done and other stuff, but at least like they have now made like guidelines in this field, so that they can have face to face visit, they can see patients, they can prescribe medications. um, then But again, there are challenges again. So this was a report by the US Department of Health and Human Services, the Office of the Inspector General. They say that there are like multiple challenges of using telehealth in the behavioral health services to Medicaid, which is the insurance by the government. And they said that there are the key challenges during this is like provider and enrollee training, internet connectivity, privacy concerns of the patient, and technology costs. So so these are the kind of like challenges in application of telemedicine. Like infrastructure, you need to set up internet access, high speed internet for data transfer is needed. And the patient or should patient and healthcare professional both needs to be well versed in the technology. Only then these telemedicine application work. Then there is a lot of concern about patient healthcare information, because all this information is stored in the system, and there is like that data protection, data breach can happen. Then the use of the data accuracy and the timeliness of all these telemedicine application is also very important. And then of course, not we need to see the patients to see what's going on, and there is like medical liability issues are there, because a lot of times sometimes we can miss a diagnosis, we because we are not seeing the patients directly. We are So there are a lot of things, physical examination is not there during telemedicine application, and so there is again like medical liability issues are there, fraud and abuse issues are also there. So these are kind of like challenges in telemedicine applications worldwide, and it is like not specific to any particular region. Again, there are like many applications in healthcare, especially in India, like acute and urgent care or referral. Universal accessible healthcare is very important. And follow-up for chronic diseases, integration of healthcare data, getting the data of the healthcare at the state level, at the regional village level, district level, is like really very important, because that is how you can make policy decisions, depending upon the what kind of what is the need, like what are the things, like which we need to improve the healthcare of that particular district or that particular area. Then the education, patient education, and the healthcare professional personnel education is also very important, and which is a very good application of telemedicine, which can be applied in this field. Um, this is from a website, like how like if we have to implement telemedicine, we try to find like what is the need, like, or what's the problem, and then try to form a team, and like IT infrastructure, like what do we need, and then trying to how making a case, how do we get a political and financial buy-in, and whether it is the right technology, and what are we trying to achieve, whether we are trying to do something to improve the just the education, or we are trying to provide like curative services, or telemedicine based care, or is it just like education, or is it just the data we need. So these are the things we need to understand, and then designing the workflow, partnering with the patient, preparing a care team, implementation, and then like how do we evaluate success, and how does it work. So these are the kind of like basic steps we need to set up telemedicine at rural healthcare level or any level. And these are the kind of like resources for telemedicine implementation. Like this is from US HHS website, and this is American Medical Association. So we can get like these. There is a lot of um, uh, information is there in these websites. So I think in key areas to focus in India for telemedicine is maternal and child health, to improve the maternal mortality rate, infant mortality rate. I think this is the key, like to how to implement, consolidate these services, and like to have like immunization services, health education. Then it can be also used in like chronic illnesses and psychiatry disorders. There should be like in greater involvement of private sector enterprise along with the government, and consolidation of existing infrastructure. Like for example, like we did like a lot of work of telemedicine in 2000 and 2005, and like up to 2010. But then like because of lack of kind of financial support, and there were like some other um, uh, reasons, like it's kind of we are back to square one. And then like there need to be like greater coordination between the governmental agencies, and centralized initiative should be there. So there are like a lot of players are there: Ministry of Health and Family Welfare, Ministry of Finance, DIT. um, uh, I think that also we need to have like a greater coordination between the different governmental agencies. Um, I guess that is. I think this is enough for now, I guess, and um, that's what I would say. So this is like a Kobe Bryant, like he's a basketball NBA Hall of Fame player. Like he says that everything negative, pressure, setbacks, challenges. There are a lot of challenges in India, but uh, it's all like opportunity for us to rise. So and if you guys have any questions, like I would be happy to answer them. Thank you.
Thank you so much, Dr. Mathur, for this, this brilliant presentation. You have widely set up the, scope of telemedicine and taken us through what it really entails. The presentation is now open for interaction, but before that, I wanted to ask you that will you share the presentation with us, because there are some links in the PPT that we can see that there are some resources in it. So will you be
Yeah,
sharing it with the
yeah,
group,
yeah.
or
I can share. Yeah, I can email it to you, and then like if you want, yeah, you can
okay,
send it.
okay.
Yeah,
So the
definitely.
yeah, so now it's open for questions. You may please either raise your hand and I'll unmute you, or you can unmute yourself and ask straight away.
Sure. Yeah, I'm trying to. Sorry.
You can stop presenting, Dr. Mathur. Okay.
May I say
Yeah,
something, Dr. Ruchira?
yeah, Dr. Pujari, please.
No, I was just thinking there are a lot of participants here, I think, who also come from um, a medical background, working in the field of community health. So we look forward to your inputs and also to your comments and uh, in this area, particularly who has been working in this area. And thank you, Dr. Mathur. It was really very, very enlightening to hear you on telemedicine and your work in the state of Tripura. And have done some work, not really exactly on telemedicine, but really interested to know because we recently had a program for a group of, as you were saying, a group of government functionaries at the grassroots level, and the knowledge and awareness levels are still very, very low in terms of how to access it, how to use it, and there are a number of challenges as you were just mentioning all of them. So of course we need to address each one of them, and that there are strengths and weaknesses as well, but it was really, really very enlightening. So, can we have the participants who are, I'm sure there are people from NHSRC and other medical organizations here, so who can also kind of pitch in? Dr. Mathur, I just wanted to understand, like, of course, uh, particularly in the rural context, we work for rural development. In the rural context in rural India, there are issues of uh, broadband internet, like, and of course, we now number of people can access smartphones. But I just wanted to also understand: is there any cost involved in accessing these services, or they are always online, and or are the people also required to sometimes visit those facilities for live consultations, video consultations? Does that also happen? Just want to know from you.
So, I think it's a very good question. Lot of time now, I think mobile health or like mobile based applications are there. So I think in one of the websites in India, like this they have this in my presentation also, like this RCH portal,
Yeah,
which is maternal and child healthcare. It's like all mobile based. So
yeah,
it's like I think it's very accessible now in India. Has one of the highest number of this mobile penetration is very high in India. So I guess these can be used by everybody. They are like not very expensive. I think there is the data cost is involved. Like I don't know how much data transfer and all this stuff is. The different plans, people they have like different plans for data transfer and all these things are there, but I think they are reasonably cheap. They are like not very expensive. um, e-Sanjeevani, the portal of the government of India, that is, um, I I think from my understanding, and I have not used it, like but from my understanding, I think it is like a online registration system. Some services are available, and but mainly it is like, and then there is a like e hospital or e-hospital is also there, which is also kind of like online registration services for in the bigger centers. So basically I think it is not for rural areas, it is for the bigger centers. There are like telephone numbers, and then they will do the online registration system. So I guess like this kind of system is there. I
yeah.
don't know whether I
Okay.
answered your question, but this is what my
No,
understanding is.
yeah, yeah. And also, are these text, they are there in vernacular languages, or so for rural people to access them, and to understand them. I just wanted to know, I mean, how do
Yeah,
they?
that is also a good question. Actually, I have not thought about it, but the what the tablet-based services like Anmol, I was looking at the website itself. Like I think it is in the they are used it like very like pictorial, and it's like I think it is in Hindi also. So,
Okay.
but I don't know whether like other languages are involved or not. So I don't know about it.
Because there are challenges there, and of
Yeah,
course,
definitely.
and
But
the
it has been working. So I don't know, this has been working, and I guess we might need somebody, if you need to know, then we just need to, because it's like working fine. There are like 100,000 Anganwadi workers, like 1 lakh Anganwadi workers already have, they are using this Anmol based
okay,
tablet based application system. So it's there. So I think they are using it mainly for getting the data.
okay,
So it's like, because telemedicine has different applications. It's like it can be like patient and doctor related, like curative and other is like to get the data, disease surveillance. So I guess it is mainly the RCH portal, the maternal and child health portal. They are mainly to get the data and get these people in the system, so that they are not lost, and then ultimately like RCH portal, so that the beneficiaries, they can have um delivery in the hospital. They are getting all the nutrition, like iron, folic acid tablets are there. They're getting proper nutrition, like breastfeeding advice, and all this stuff is there. So I guess this is a kind of that kind of application of telemedicine, which is not like prescribing medication per se, but it is education of the patient, disease surveillance. um, I guess it makes sense. So
thank you,
so
Dr. Mathur. May we
sure.
also have other participants if they are interested?
Yes, the panel is open. Actually, participants can unmute themselves, and if they have any comment or any question, they can ask.
Hello, Dr. Mathur. Can you hear me?
Yes, Dr. Divya, you're audible.
Yeah, that was a very nice presentation. In fact, I'm the nodal officer for telemedicine from state of Kerala. Actually, I have heard about the history of telemedicine many times, like ISRO works and the Onco network, etc. But what is being happened, what is actually working here is really that Sidak Mohali Wala, the same thing, the eSanjeevani platform. But as I understand, there are multiple reasons why there should be telemedicine, or there should be a government-run telemedicine platform connecting all these public health institutions in India. Um, and what is important is, as we all know, in the rural health care centers, like in PHCs, we do have a rush of OPs, like a single doctor handling around 200 to 300 patients in a half day time, wherein if we really scrutinize each and every case, there will be only 30% of these 200 persons who actually need the direct consultation. Majority will be there for a reference, for an advice, for a prescription, for continuing medication, for some counseling, for a prescription for deworming drugs. Probably in new era it is an upper respiratory infection, which is actually a questionnaire based screening, which is possible to identify whether it should be treated as inpatient or should be left to natural recovery. So that this is one thing which I consider the most important cause. And the definitely the out-of-pocket expenditure, the accessibility are the many other issues as far as Kerala is concerned, which is rich in healthcare institutions and medical care facilities, even in private sector and government sector. It is not the accessibility, but the selection and what is it, stratification of whom to reach who, then who are not beneficial by this telemedicine should also be advertised in a very good manner, or there should be scientific identification of the subset of patients who can access the telemedical care. I mean, what is teleconsultation, that should be done as a, what is that, customized. There should be a scientific work on that. Like, it cannot be done uh, universally. Like, you can't do the stratification by each and every for all the departments. Like, only an oncologist will know which subset can be consulted, uh, which subset of oncology patient can be some consulted by telemedicine, and there should be systems for that. And this is a huge work all over the world. Probably I am basically a radiation oncologist, so I am talking in terms of oncology, but I understand that in medicine, in surgery, even in gynec, somebody will tell that there is no point in surgery patients consulting in telemedicine. But I do have to say that there is a subset of patients who can be benefited. uh,
Dr. Divya, if I just intervene in case I forget, just to ask you, which group of the population, in terms of age group, in terms of also social, caste class group, are the ones who are accessing it mostly from rural
Actually,
areas?
we have done an analysis recently, which just found out that the majority of patients who are accessing is 40 plus. That also females, and also it is well benefited that is this highly satisfied subset of patients are who are having a public health facility nearby, just because they are getting free medications from utilizing this. We have given a government order to all the public health facilities to honor the prescriptions and the test request by the telemedicine platform, e-Sanjeevani platform. So it is all loops of completed. So probably this is how we could translate that. So that is it.
And
We
is it,
even,
huh,
yeah, yeah.
is,
Please go ahead.
is it only for the RCH concerns, or what?
No, 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 no. The telemedicine platform we just started from June 2020 when the COVID was on its peak. So we were trying different platforms, but eSanjeevani has, sir rightly pointed out, that data privacy is a big issue in Kerala. So we just relied on this eSanjeevani platform just because it is a Government of India platform and the data is secure in the hands of the Government of India. So actually, we started with a general OPD which was working from morning 8 to evening 8. Then we understood the specialty needs of the patient, and we started to onboard all these premier institutions like RCC, MCC, and IMHANS. Like, all these oncology patients were traveling across the state for their follow-up chemotherapy and follow-up services. So what we did was, we just started to onboard these doctors, and we are tried to arrange locally their chemotherapy and consultation from this. I mean, chemotherapy facilities were arranged locally, and consultation from the concerned doctors. So that went well, and we started this specialty OPDs. We started with the four main broad specialties, and later on expanded to, now we are having 56 different specialties, on which one is DEIC, which is the, uh, as you know, the children with special needs who need to be therapy supported. So DEIC supporter is special services are also onboarded in the eSanjeevani OPD, which was a very big blessing for this children of this
Yeah.
DAC kids. So now we have started our doctor to doctor consultation also. Actually, we are providing it from all over for PHCs and UPHCs. Sorry if I'm not, if I'm taking more time.
No, no,
So
thanks a lot.
Okay, Dr. Divya, we will hear more from you. Actually, there is a group discussion session and open interaction session where we will invite you to talk more, because we also want the state experiences and the successful cases that are there to document and to present. But I don't want to keep Dr. Mathur awake because I know it's very late.
Yeah, yeah. Sorry,
Just a
sorry.
moment,
Thank you, thank you.
nearly midnight. And if you have any, to all the participants, I request you that if you have any direct question to Dr. Mathur, please unmute and ask, or we can, wrap up the session and then move on to our next session, which is a panel discussion. I don't see any raised hands, and no, there are no raised hands, so I'm assuming that there are no questions at the moment. So let me take this moment to thank Dr. Mathur for taking his time and preparing the presentation, sharing it with us. And we do look forward to working more with you on this. And I hope that we will have more interactions. NIRDPR, as you know, has been working in the policy arena. Basically, we are not medical professionals, but we are, social scientists. We work with the ministry on policy areas, on areas of evidence and research, etc. Those areas we would really like to work with you and understand the evidences that are coming up on the impact of this kind of a technology transfer and what are the scope for the rural population. Before we close the session, I had just one question to you, and
Yeah,
I mean, we can also maybe think about it,
yeah,
that
yeah, sure. Please go
we
ahead.
talk about interdepartmental coordination, that because we are from Ministry of Rural Development, we don't work with the Ministry of Health, but from the Ministry of Rural Development. And you spoke about Anganwadi, which is something that kind of very close to what the Ministry of Rural Development does with women self-help groups. So do you see any kind of successful cases in India where self-help groups could be onboarded with telemedicine initiatives, or do you envisage that there need to be some kind of training on the areas of health or maternal and child health to be linked with telemedicine facilities? Or can we talk about this kind of a coordination where the self-help groups can be onboarded on this, and different departments can be brought in to coordinate and make it better? And just to get your insight on that.
Yeah, I think it is a very good question. Um, Anganwadi workers are the healthcare workers at the sub health center level. Like, it's, I think, the first point of contact to the general population, and they are actually not paid very well, and they, like, their salary is very low. And I have, like, interaction with them. Like, when I worked, I was like fascinated by, like, community healthcare and like telemedicine. So when I was working in Kanpur, like, I had interaction with the Anganwadi worker there. Like, they are like, they are not paid well. They, most of the time, they are doing this thing just because it's a good thing to do. They want to keep busy. And so I think in that area, these self-help group can really help. And it's just that they just need proper training, and which can be provided by telemedicine. And I think they really make a lot of difference, especially in the maternal and child healthcare and in the immunization. So if you if you say to me, like, what are the really important areas in which telemedicine can make a lot of impact in a short period of time, it is these areas, like, where we do not need lot of infrastructure. We just need, like, education services to be provided, and maybe a little bit of better compensation to the healthcare worker working at the grassroots levels, like Anganwadi workers or the self help group workers who can go to the community, just provide awareness about the health related issues, about the immunization, about the delivery in an institution. I think that will have really great impact. So
Yeah, thank you so much, Dr. Mathur. Because in fact, after this workshop, we want to come up with some kind of an outcome document which can be, a proposal for a model to kind of take telemedicine further than what it has already gone. So I just wanted to know that whether it will be, feasible addition that if we say that we want to keep the self-help groups on board, knowing that these women have absolutely no experience of healthcare profession and have no medical experience whatsoever. So are
Yeah,
there
like
involved?
yeah,
So I just
all these all the Anganwadi workers, all the workers, they are like just like kind of like social workers who are working in this field. They all of them, they first get some education by the health officer at the local district levels, and then like they provide the information to the general population. So
Hmm.
they are not like healthcare professionals. They get some training by the government of India at like I don't know the duration of the training, but they get some training for some time, maybe and then like they go. So they are not like trained healthcare workers. So they are like all the they are all of the same population. Like they are the volunteers from the same population in which they are working, of the same village or something. So they are the same workers. Yeah. So it can work out. Like I think it should work out.
So, with that, let me thank you on behalf of National Institute of Rural Development and Panchayati Raj for your time and the presentation. And
Thank
we
you.
truly hope that we will be able to interact with you on this a little more in little more detail in a more focused program on telemedicine, probably because today is mostly a larger workshop. And thank you for your time. And I
Yeah, thank you very
request.
much for the invitation. Thank you.
Yeah, thank you so much.
Thank you. Bye
And
bye.
we would contact you a little later with some more details and logistics, but that will be from our department. Thank you so much, Dr. Mathur.
You're welcome. No problem. Take care.
So, for our participants, we still have around 10 to 15 minutes till our, our panel discussions begin. So if you have any comments in the meantime, or if you want to have any kind of input that you have, you may please unmute yourself and talk. My other request to you is that I will be sharing a feedback link to the WhatsApp group and also in the email addresses that you have shared with us. I request you to please use that link and register yourself to the training management portal, because your certification depends on your registration in that portal and your registering your feedback of the program. And these feedbacks really help us to kind of consolidate and improve our programs later as well. So we really request you to use that link and register your feedback. So we'll be sharing the link in maybe 5 minutes, and then you can use it, please.
So the next speaker will join us at 11:15, or can we have it a little early?
Let me just see if
Okay.
sir has joined. Dr. Karunakar Reddy, are you in the meeting room? I don't think Dr. Reddy has joined yet. So let us wait for 10-15 minutes. Once he joins, we'll start the next session. Dr. Reddy, am I audible to you? Good morning, Dr. Reddy. Am I audible?
हाँ नमस्ते नमस्ते रुचिरा जी कैसे हैं आप
हाँ ठीक है सर. Actually हम लोग अपना पैनल डिस्कशन शुरू कर सकते हैं because our last presentation is now over.
अच्छा
And if you are ready, we can straight away start with your program. In which case, you will have a little more time to talk and interact.
okay so then what we'll do is let me open up my PowerPoint presentation so if you can give me share my screen
Yeah, I have made you the co-host of the meeting, so you should be having the
okay so let
host
me
control.
share the screen then
Yeah,
so
sure.
can you see my screen No?
Not yet.
Not yet okay let me
It takes some time to.
let me see how we can do that so share screen got it and touch screen
Yeah, yeah. Your
Okay.
screen is visible.
okay can you see now
Yes, so can you make it full screen because it's.
Sure. Okay, better presentations.
If you do it from beginning, we'll be able to.
Sure. So I'm coming there. So let's see how I can. So I can remove everything and share the slideshow.
F7, sir.
F7. Okay. Thank you.
Full screen mode. Otherwise, you go down at the bottom, there is a full screen presentation mode. Right, next one, next icon. Yeah.
Yeah.
Right, sure. There we go.
Yeah, we can see it, sir. Sir, before I hand over the session to you, I would like to introduce you a little bit to our participants. We have already had a short introduction. Dr. Karunakar Reddy is the managing trustee of the Social Trust. Dr. Reddy has practiced cardiology for nearly 25 years, like more than 2 decades of experience. And after retiring from medical practice in 2014, he started his charity work in India. He has had wide level charity work in rural areas and a lot of experience with working with rural communities. And he feels that his achievement in life, worldly and spiritual paths today is because of the education he has received in India. So deeply nationalistic view and a deeply charitable view that he has. With that, he has started working with the rural communities, and he will be talking about the work of telemedicine that he has done with actual practical experiences and also the scope for it, like how we can take it further and what more can be done in this area. So with that, Dr. Reddy, please let me hand over the session to you. We have nearly 50 participants from different states of India. Some of them speak Hindi and some of them are from states that do not speak Hindi. So you may have a mixed language while interacting with them. And they are mostly nominated health practitioners and consultants from different states. But we also have some officials who are working with the communities through the RD division as well, and some NGOs who are working with the community as well. So with that, I would like to hand over the session to you, sir. You may please start.
Thank you, Ruchira, for the introduction and namaste to everybody. And time is the most precious thing. So let me jump right to my sharing experience, as you can see. So let me give a little introduction about Swashodhan Trust. It's a social rural entrepreneurship. As you all know, entrepreneurship means a startup. So what we are doing is we are starting digital villages. So the vision of the Swashodhan Trust is to make, these are the keywords. So I think probably you're paying attention. I'm moving my cursor to bring your attention there. Hopefully you can see my cursor moving. So what is the thing is we're going to make the vision of the trust is to make a self-sufficient, self-sustaining, dharmic digital model village to prevent urban migration. And this model should be of high quality, low cost, and using local resources. And this model should be easily replicable in any village in India. So how are we doing this is by connecting. So digital village is what I mentioned. It's a startup of digital villages. So how are we going to make the village a digital villages? By connecting the villages to internet and making the connections as digital highways. And recently, the great man Abdul Kalam, so he mentioned the word that urban amenities should be available in rural areas. This he coined it as PURA actually. So providing urban amenities in rural areas. That's what PURA stands for. But anyway, so like it was his vision, but we are happy to make it into a reality. So now, what is digital village? You remember what I mentioned? Swashodhan Trust is a social rural entrepreneurship in making of digital village. Remember these keywords: entrepreneurship. So at the end of the slide, I'll summarize what I mean by entrepreneurship. So digital village means what? So what are we working? Our definition of Swashodhan Trust is what are the main things which a person needs? Is digital education. We have already started the work on the ground. Digital health, we have already started the work on the ground. Digital and physical jobs, yes, we have already started. Digital panchayat, we have given the panchayat actually a laptop and all the necessary requirements to make it a digital panchayat, but because of lack of knowledge, they're not able to use it. So digital agriculture is one of the other important limb of a digital village, but we are not working on that. We are trying to associate with the NGO which are doing digital agriculture. Now, the other keywords were self-sufficient and self-sustaining. Now, what is a self-sufficient? So, a village means, born in the village and die in the village. In between, what are the things which are needed? Everything what is needed from the birth to death should be provided in the village itself. That's what is the definition of self-sufficient village. So, what are the components of the self-sufficient village? Is education, very important. Second is health, which is the topic of discussion today, and then livelihood, as I shown in the previous slide, providing digital and physical jobs in the village itself, and public services means all the government things should be available online. So what is the vision? That this is the vision, and the mission is to replicate this model in as many villages of India as possible, and most likely to all the villages in India. And again, the route, how we're going to do that is by opening digital highways. Now, why villages? As we all know, so this you all have the statistics. Most of the people live in the village itself, and then the huge potential because the rural areas are unexplored. There's not much of growth happening in the villages. Unexplored, huge opportunities for growth. Now we all know why people migrate from rural villages to urban areas. Causes of urban migration, you all know. I'm not going to spend time on this. And then lack of healthcare, we are also aware of this. Lack of doctors, lack of physical access of beds and nurses and all those stuff. So then what is the solution? So problems are plenty. The challenges are, so to provide two challenges, to provide high quality healthcare and also lack of physicians going to the rural villages. Those are the problems. And how are we going to solve that? Those two challenges is by digital telemedicine. So what is this? I'm going to show you a little more detail, but those people who are lay people who don't understand. So instead of the doctors coming physically, we're going to bring the doctors virtually. As you can see in this laptop, the doctors are going to come through virtually through electronically. And then not only MBBS doctors, we're also working on, we are providing specialist services also through telemedicine. And what are the other requirements for the healthcare is having a pharmacy and some labs and diagnostics. I'm going to touch on it. And the important component for telemedicine is electronic health records. I'll take you through that also. So now the difference. So doctors know that so this slide shows you the difference between a physical clinic and a telemedicine clinic. Physical means the doctor should be in the clinic itself. And this is the biggest problem, as you can see, as depicted in this slide. And the subsequent slide, this is a telemedicine. So I'll show you a little bit more, a closer picture. Now, having understood the difference between physical clinic and a telemedicine clinic, physical doctor, virtual doctors. This is the virtual doctor here, and this is the physical doctor. A little bit more closer picture of it. So there are three components in telemedicine. One is the patient component side. Then the other second component is the physician point of view. And the third important component is the electronic health records, where the patients, the village clinic, and the doctor come to play is the electronic health record. This is a very important component, is electronic health records. That is what makes possible the telemedicine being available in rural areas. Now here, then this, as you can see, there's no doctor. This is a person who didn't even pass her intermediate. She is trained to enter the data electronically into the electronic health records. The electronic health records, I'm going to emphasize what are the important points. Sharing my experience about electronic health records, I'll share in a little view. It should be user friendly. So this lady, as I mentioned, who knows how to use a smartphone, that's good enough. So then she enters all the data, history, all the why is she there, enters all the vitals and present history, past history, family history, social history, and then she does some labs also, which I'm going to show what labs are done. And then she enters the information into the electronic health records. After she enters the information, she notifies the physician who starts the consult. So when he initiates the consult, he gets in access to electronically through the electronic health record what information she has entered. So, and then he reviews all the information. Then he starts a teleconsult, video consult. So this video consult means, so this is what happens. Now you can see me here, the physician showing up, like this is virtually, instead of me physically being there, this virtually I'm there as a virtual physician, and I can see her on my screen here. So we both interact. I ask her already I've reviewed the chart and ask her questions. If I'm not satisfied with what information is entered, I can talk to her and then get all my information, what I need. And then after I get all the information, then what is the next thing to do? I'll review all the labs and all the old charts and all the information which this lady has entered. I'll review all the information. And then I'll make my diagnosis. And then further tests what are needed. So I can enter the diagnosis into the electronic health records, and I'll show you a prescription how it is generated. And then then the option is to order some tests, so which I can do, and then medications and referral. Or the last thing is if you have to send her to a hospital for tertiary care. So all these things I do that, and I enter. Either I can enter it, or we have trained this girl to enter that information into the chart. So we opened our electronic health record first clinic in October of 2020. So we have more than 2 years of experience working on telemedicine clinics. And this is where the talk is being done from the experiences. So the electronic health records is the playground where the patient and physician interact. This is where the electronic health records play a very important role. So we are working on developing a rural electronic health records which fits to the needs. Very important component of it. So that's where, if any expert is there, so who can help us, because in India, the electronic health records are not developed. I have experience of 16 years of using electronic health records in USA, and the electronic health records are very poor here and need a lot of improvement. But anyway, so if anybody is in the group who can help me with in making of rural electronic health records, that'll be very, very helpful in providing high quality, low cost healthcare in rural areas. So now what are the kinds of electronic health records what we need? Electronic health records are 3 ways. One is for the general clinic. So like as I've shown, so this is basically used for health clinic, telemedicine clinic, where the information is entered and the doctor looks at the records, and it is used for practice. The second way is everything what we are doing is research. So what information? Because all the information is entered digitally, all the data can be analyzed in different permutations and combinations and get we can make evidence-based, all evidence-based prevention, everything about diseases and every information can be checked and we can gather reports and conclusions, and we can do research. So this is the health clinic, and purely we did, a research-based electronic health records. And so this actually, Swashodhan Trust was fortunate enough to do a free COVID isolation center in a village, which is called Gollapalli village, because of shortage of time, which I got. Otherwise, I would have shown you all the information, what data we got, and how beautiful is that. So we came to the conclusion that cough, loss of taste was the common symptoms in all the people with RTA positive patients. So this was a simple study what we did. And then later on, I think German people published a study, with all their expertise and everything. Yes, loss of taste was the most common symptom. So see, simple things, we could have done it. So we don't need a big country like Germany to tell us. So when through electronic health records, this is my experience. Yes, this is very, very important. India needs is evidence-based medicine practice, which I'll show you pretty soon. What I'm talking about. Very important component where we need data and we need to develop criteria which are suitable for Indian population. Not Western standards cannot be applied in India. Very important, I think. And then a combination of this is the hybrid, where we can enter the data clinically, but at the same time, based on the data what we have entered, we can gather reports. Very important. So this is both. So purely for health purposes, purely for research purposes, and a combination of both. This is what we are working on, the middle model. So we are also working on now, the telemedicine is progressed, and there is already a doctor, Dr. Vivek. He's a young man. He's from Gujarat. He's already set up tele-ICU units in bigger primary healthcare centers. But we are going to work on it so that the rural ICU centers are also available in rural India. So this possibility is we are working on a timeline of 6 months. Once we set up the clinic, then we are working on setting up the tele-ICU clinics in 6 months in Adilabad. Now, having worked in this village, so we're going to open up within few weeks a clinic in Adilabad, as you all know, which is a remote district. So where the quality of healthcare is very poor. So that's where we're going to set up this, and we are working on setting up this tele-ICU. The goal is to set this up in 6 months, and we can. So the other thing, as I mentioned in medicine aspect of it, and providing it is not only seeing the patient, but providing them medications. So we have started Pradhan Mantri Jan Aushadhi in the hospital, so Chipalpalli Hospital, and we're going to set up the same thing in Tosham village in Adilabad. That's where we're working. And then we're going to set the same thing also. What is the importance of Pradhan Mantri Jan Aushadhi? Two important factors. One is all the medicines which are sold in the pharmacy are quality tested. As you know, there's a lot of medicines which are generated, a lot of generic companies, they're not putting proper content, and they may not, even the content and the quality of the medicines, generic medications, are very doubtful. Here in Pradhan Mantri Jan Aushadhi, the pharmacy, all the medications are tested to make sure the quality is good. That's one important point. The second important point is they are much cheaper. So at least when compared with generic medications, they are 50 to 80% cheaper. So you can ask me some questions in the question answer sessions. You can ask me some questions. Hey, how did you come to that conclusion? What experience do you have to say that? I'll leave that during the question answer sessions. So then, as I mentioned, the other thing is the diagnostic center. So we have to have when we need to do some tests, which is important for the doctors to make the diagnosis. Currently, so the best thing is, we cannot put labs in all the villages. So what we need to do is, this is my experience, is the test should be made very simple. How simple it should be. So I'll share this finger stick. So you all know how we check our blood sugars, right? So it's so simple, give a stick and then put it on a strip and put it in a machine, it'll give you a reading. So that's the way the rural medicine needs to go. Very important test, and I'll show you what we are doing to get all these tests done in the rural villages. But right now, we are doing two things. One is we're checking the blood sugar to see if the patient is diabetic. And then also check, this is one other important component which is plaguing all the women in India, is anemia, where the blood count is low. So, but we can check the blood count by the finger stick methods. These are the two things what we are offering. And then, so as I mentioned again, in my experience, finger sticks are the beautiful things. Otherwise, you have to draw the blood. It's all laborious process. So high quality, low cost, simple to do. So these are the two tests what we are offering now, but we are trying to collaborate with esteemed institutions in Hyderabad to develop this finger stick method. So I'll show you pretty soon. And I think probably this will be very helpful if somebody can help me to reach this gentleman, Sunil Raj. He is the Director of Public Health, and he says he has got several things which we can check, several tests what we can do, like renal, kidney functions. Renal means kidney function test, liver function test, lipid profile, PT-PTT. So, and I'll show you down the list. So he says he has got this, but I've been trying for a few years. So it is going very slowly. If anybody in the panel can help me to expedite this, that'll be of great service to me, and I can provide great service, high quality, low cost care in the rural areas again. That's our goal. Remember, high quality, low cost, and better care actually than urban areas. So now, again, as I mentioned, finger stick. Remember, so as the goal objective is to develop simple tests. So where all the tests can be done locally in a few minutes. For the matter of few minutes, we should have the results that help the doctor to make the proper diagnosis so that he can provide right treatment. So what are some of the finger sticks methods? What we are talking about? Blood sugar is already there, hemoglobin, renal, kidney functions, liver functions, pregnancy, lipid profile, troponins. This is one of the important components when a person has got a heart attack, which is active, this level rises. So we should have a finger stick method. If a person comes to the clinic with a chest pain, do a finger stick and make a diagnosis. And then this is another one which is important to check if a person is in heart failure. People have shortness of breath. So this is another thing. And then the other important thing is for fever, if you do a finger stick, that should be able to give us a diagnosis of any of these diseases: typhoid, dengue, malaria, influenza, COVID, chikungunya, so hepatitis and other meningitis and all the other diseases. It's very important. So when a patient walks in, do a finger stick and make a diagnosis and treat it appropriately. So again, these are the simple methods, and we are working with IIT here in Hyderabad. We are also approaching JNTU to do research. So this is, again, you remember we started off saying social rural entrepreneurship. So vision of Sashodhan Trust, these are the things what we are working with these institutions to create these machines which are entrepreneurship, which will not only help in India, in all the villages of India, they can be used worldwide also. So, and then digital x-rays. So x-rays, so we want to buy a mobile x-ray. We didn't, so we're in the process of looking into it. So we'll buy a mobile x-ray, and that mobile digital x-ray again, so that can go to cluster of villages and then do x-rays and then transmit those things digitally to the doctors. This system has been in existence for 25 years in USA. So all the technology is available, but we have to all unite and get these things available to villagers. Then ultrasound, this is a very important test. So because we can check through an ultrasound everything here: cardiac, vascular, of course, heart, blood vessels related, and abdominal problems. Like if you have any abdominal pain, do a simple scan to check if if the problem is happening from the gallbladder, pancreas, and you all know appendicitis, colitis, all these things. And also, of course, obstetrics and gynecology. We don't want to explore into this right now because government has got limitations because of the girl feticide. So there's a lot of restrictions, but we need some help. If you want to do research, we should have access to this. So if anybody is in there, very, very important diagnostic tool to have. So how? So, so what is the progress? This all technology is available. It's not new. This is what I want to show. So this is the ultrasound, which I just now spoke about in the previous slide. So they have, look at this, how small this probe is. And you can see the person is heart. You can see the person's heart here. And then this is your smartphone. In the smartphone, as you can see the pictures, how simple it is. So you don't need a lot of expertise. This person can be trained, and the pictures can be captured like this in the smartphone. And from the smartphone, then the information can be sent to an urban center for interpretation, or any place. In fact, any place in world you can send it because the information is digitized. So we can check the blood vessel supply in the neck, heart, as I showed you in the previous. Simple, very, very simple, portable, and the images come in smartphone. So we need this technology again. So we're working with IIT. The second thing is the dental care is non-existing in rural villages. So people have a lot of tooth problems, and then there's no care. So what can we do to provide this much needed rural health, rural dental care? Is there's a camera which is it's called intraoral dental camera, digital intraoral dental camera. So we can take pictures like this. Very simple. It's not complicated, and transmit those images to the dentist. And then the dentist can see whether it's like, hey, the person has got problem with the disease or with the gums. And then we want to do a study where the dentist makes a diagnosis with these pictures, and also then the same patients are checked by the physically checked by the dentist to see what is the like sensitivity and specificity of making the diagnosis of the dental disease with the intraoral digital camera screening, identifying the disease, dental disease, and also to see how deep we can make the diagnosis. So simple study, and we are planning to do this study and use this camera, and once it is proved, then we can it is such a beautiful tool, and all the people in the villages all over India can be screened very, very, very easily. Uh, so this is what we want to work with IIT. So this is an Indian made company. I'm happy. So we're going to promote this as a social entrepreneurship. And so this can be easily used in 1 million villages of India once we prove that. And then, so this ECG, the ECG is important. A person is having a heart attack or irregular heartbeat. It's important to check. And I'll show you what we're going to do in the next slide, what we are doing currently to obtain this ECG in our rural clinics. And then digital stethoscope. This is an Indian made. So what we need to do is, one of the drawbacks is that the person in the clinic who is not very qualified, she cannot check, she cannot do examination as a doctor can do. So we are circumventing that problem by instruments where we can record the stuff. Physical examination can be recorded, and the doctors can hear at the other side. For example, so she cannot listen to the heart and tell us what to do. That's missing. So, but we have digital stethoscopes where this stethoscope can be put on the heart, where different areas of the heart which are important, and that information is recorded digitally, and it is with AI, so you can clean it up, and actually can make a diagnosis of the heart sounds, and those sounds are recorded into the electronic health record, and the doctor can listen to it. So heart sounds and lung sounds and abdominal sound, we measure the intestinal motility, all these sounds can be recorded, and the physician can hear those sounds actually much better than what he can listen physically with the patient. So this is several instruments we're working on, which will help the physician. That is other things what we need, and low cost tablets, laptops for digital. Since everything is done digitally, so we have to develop some. So that this cost of setting up this rural telemedicine clinics is low. So we have to find low cost these instruments so we can set it up easy. I'll show you at the end of the record. So how much at the end of the presentation, how much it is costing us to set up these clinics. Everything is documented. Electronic health record app is very, very important. So because as I mentioned, so in the previous slides where I showed you, on one side is the patient, on the other side is the physician, and the meeting ground is electronic health records, which makes this possible. Very important. And as I started off, so we need this help. If we want to develop this app, rural electronic health records. So if anybody is listening and has got that expertise, we would like to meet him and see how we can develop this. This is very, very important. So one more thing, let's make it very clear. So what we do through rural thing is to identify the diseases and do primary care or preventive care. And then we can also, so this is what I was talking about, the ECG. So this is the ECG. This is our machine, which is so small, as you can see. And this is the conventional ECG, what it is used to do the ECG. Actually, comparatively, it looks big, but this is very small, as you can see. I'll show you here how we do it. It's a very, very small strip, like maybe about 3 centimeters by 2 centimeters strip. And through that, we are able to do. The technology is advanced. In other words, and I bought this machine from this small thing, which costed about $145 from US. And how we are using it, I'll show you. So this is the SST rural clinic way of doing ECG. This is the conventional method. And test takes 30 seconds. So I'll zoom on this and how the test is done. Here, as you can see, this is the person who is recording the thing. She is recording it into the smartphone. And what the patient has to do is to hold this between 2 fingers, like this, here, as you can see. So she is holding it between 2 fingers and putting it in the leg. So So this is the way the electrical activity from these two hands and the foot is measured, and out of which comes this EKG on the left side, what you see. So the advantage of this, it takes 30 seconds. And here it takes 15 to 20 minutes. And look at the setup. All that she has to do is this. Here the patient needs to be hooked up, has to be taken off his clothes and hook it up. All these leads have to be hooked up. Nothing simple here. And then you need technical expertise to do this, where this one is no technical expertise. So this is the greatest advantage. So these things needs to be developed. So since I knew, I bought this from USA, and then we are doing this. See how the EKG is recorded. This is 6 lead. Now the conventional EKG records 12 leads, but we are recording 6 leads. And we can make a diagnosis whether the heart is beating regular, irregular, and if the person is having a heart attack, we can make out. So, and then the other advantage, as I mentioned, is quality is excellent. So we can make diagnosis through this. So high quality, low cost. So here the cost per patient to do this is almost 10 rupees. So this we are not using it. So this is for the person to employment in the village. So that lady gets 10 rupees for all the work what she is doing, and that's an employment for her. Whereas in hospitals and urban areas, they charge about 200 to 300 rupees. And imagine the amount of time. So you have to go, you have to, like lots of things there. You have to walk to the clinic in 10 minutes or 5 minutes since you're in the village. It's not far off, and you have the EKG done, within a matter of 5 to 10 minutes. And for 30 seconds, the EKG is done. Now, quality of EKG. So yes, we have to talk about the drawbacks of it. As I mentioned, the 6 lead EKG is a poor man's ECG. It is for screening only and not as diagnostic as the 12 lead EKG. So, but this is a great way of checking the heart. High quality again, low cost. And so the other specialties also are coming. So we are working with LV Prasad Eye Institute is in place. So in Chipalpalli village where the current clinic is running, so they come and screen all the people here. As you can see in the bottom thing, they check all the people physically. So what we are trying to do, as I mentioned, is to provide high quality care in the village itself. So the people don't have to go to the cities. So they come, so they are also working with us, and later on, they are also having telemedicine clinics, tele-ophthalmology. So we can associate with them and provide tele-ophthalmology. So through the electronic health records, we see them through virtual physicians again. And then Army Dental College, we have an MOU with them. So they come and check all this. So like as you can see in the top picture here, so we have already screened all the people in the school, all the children in the school. So now next we're going to screen all the children in all the people in the village. Again, I reminded you because the people in Chipalpalli village are fortunate, but how many villages are fortunate where people will come and check the teeth physically? So if you recall, I mentioned we want to do that intraoral digital camera as a screening method. Instead of the doctors coming physically, so we can take pictures and send it. That I think is going to be a good screening tool. There are a lot of studies which are done in US and other countries, in African countries, if I remember, but we would like to do a study. And once we prove that, then we can, that's a simple tool to screen en masse all the children and adults in the village. Yes, as I mentioned, so we're going to be next few weeks, we're going to be starting a clinic in Tosham. So yes, we have understanding with RIMS. So they have, like 1 hour where they have online specialists available. So they're going to be helping us as a subspecialty services. Every day there's, for example, there's a cardiologist, there's a pulmonologist, there's a dermatologist. So different rheumatologists, nephrologists, all these doctors will be coming online and seeing patients in the village itself. So whichever patients we refer them to be checked on that particular day, they'll be lined up, they'll be coming, and they'll be seen in the village itself. So this is, you remember I mentioned most likely we are working to have a tele-ICU in the village itself. And this is the young man, Dr. Vikas, who has got experience in the setting of this tele-ICU, the critical care doctors. Yes, we can do high quality care in the village itself. And time has come, we need to do it. We all need to work and do it. So this is the way the prescription is generated. So I'm not sure, so we need to zoom on it, but all the information, everything is generated So all the medications, all the history, past history, allergies, as you can see in red, the diagnosis, the medications, and the follow-up, all the instructions are here. So in this, a copy of it is printed and given it to the patient when she leaves the clinic, when he or she leaves the clinic, and a copy of it is sent through the social media, through the WhatsApp, email, and this copy goes to the patient for her records. So we have, this is probably, I'm not sure how many people are doing in urban areas, but we are able to do this in rural areas. So again, what our goal of Sashodhan Trust is to provide high quality and records, high quality and low cost. So this is now okay. So having spoken about, so what is a telemedicine, how it is done. So now, so people are interested. What are the benefits? Why do you want to do that? So I've categorized into different people. All the people involved. One is the villagers. So what are we doing again? So we are providing quality, high quality care by MBBS doctors. So it's impossible. So let's come to the accept the problem. No doctors are going to go physically to these villages and give them so heart from the hearts. Even if they go there also, they are forced to go because their families are behind. And so the solution is practical, very possible, and which can be easily done are the virtual MBBS doctors. And as I mentioned, we are also bringing subspecialists. So in other words, the villagers are getting high quality care through virtual physicians through electronic health records. And then high quality, low cost, for example. So if you ask me, so what is the low cost? So we have checked with the villagers. So how much we have checked with the villagers how much it costs per visit if they go to the urban areas to see a doctor, anywhere from 600 to 1000. So what is the cost for them when they come to the rural clinic is 110 rupees. This 50 rupees to the physician for seeing the patient, and then 20 rupees for the person who is entering the data, and 20 rupees is for the data, for the ASHA worker who's taking the history and putting the 20 rupees for the person who is entering the data, digital entry person, and 20 rupees for maintenance. So the whole cost of the visit is 110. And so see the marked difference, low cost, and we don't do unnecessary tests. If you go out there, as you know, the common number one cause of poverty in rural India is rural healthcare. Healthcare is the number one cost, as you all know. So I don't have to elaborate and explain how. So simple things are elaborated, and all the money is being, all these things are. You have to spend a lot of money for things. So we're not going to do that. Everything is documented. Everything is explained to the patient, and everything is given to the patient. So these costs. So for the visit. Now the other things is lab testing and investigations are mentioned. So so is very important. So we're working on it, and possibly the technology is advancing so fast that we should have this technologies, I feel, within 6 months, where the patients come to the clinic and then out goes the patient with all the diagnosis, with all the tests in the village itself, in the village clinic, and the doctors are able to give evidence-based medications and treatment. So and then, as I mentioned, that girl who was entering the data is from local resources. So we ourselves are providing 3 or 4 jobs, and then a pharmacist also 4 jobs, 3 jobs are all there already there, and then local, they are from local, and then save. So what are the other things which the villagers save? So from a place, if they have to go to the city, so they have to get up at 4:30, and they stand in the line, have breakfast someplace, stand in the line, and then the doctor sees them for 2 minutes, because the doctors are inundated with the patients. They're standing on his head, so he cannot see all the patients. It's impossible and impractical. So they are seen with 2 minutes and no records, nothing. And when the patient walks out, he doesn't have nothing. So time is a very important thing. The villagers, how much time does it take for them to the rural rural telemedicine clinic? Maybe 10 minutes at the max. So comparative, I'm just probably you can think about it: travel time, expenses. So then you go there, you stay, and loss of family time and multiple visits. So all these things are simply avoided by coming to the telemedicine clinic. And then the important thing is prevent quacks from providing substandard healthcare. Very, 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 very important. So I can give several examples. I can share my experiences. When we have time at the end, you can ask me questions. What is the practice there? I stayed in the village for 6 months. And this is not, I think, the first picture which I mentioned. So these are on ground experiences of my practical, my experiences staying in the village. I'm not emphasizing my because that's not what my goal is to, to praise myself, but I'm telling you these are the practical on the ground experiences. Everything what I'm talking about is practical on the ground experiences, not by Google Meet or thinking intellectual discussions. We are not in intellectual discussions, all these things. And I'm happy that the topic of discussion is today is rural telemedicine with experiences. So then what are the advantages of physician? Everybody should be a win and win situation. So what are we doing? So the physicians can stay at home, and then they start the clinic. Our clinic hours, most likely what we are thinking is from 9 to 1 in the morning and 5 to 8. So what the physician has to do, so she can be with the children, and at 9 o'clock when the children are gone, she can open up a laptop like what we are discussing, and she can start seeing patients. So she doesn't have nothing, nowhere to travel. She can sit at home, and that'll save a lot of time, travel, and no expenses. Just a laptop and internet connection, most of the people have in the urban areas. And imagine the stress. So you'll be saving all these things. Very important component. Travel, run, this thing, that thing. The nothing is there. She stays at home from 9 to 1, and then more patient volumes. No stress.
Reddy, I'm really sorry to interrupt you. Just
Thank
a
you.
word of caution that our next panelist is also ready, but we do hope to have you here in the panel so that we can have a combined interaction with the participants later
Sure.
on.
So I'm gonna speed up. So give me a few minutes and I should be done. So this is the advantages. These are the advantages. More patients, any city, state, and country, the physician can see, and no office expenses. And we are paying 30,000 rupees as a salary, and every patient 50 rupees. Specialists get 1 to 1, and then more important is the family time. Then institutions reduce overcrowding, as I mentioned. So there is 3 doctors and 120, 200 patients to see. So if we take care of the patients in the village itself, they'll reduce the overcrowding, and quality of care will be better. Low volume tertiary care, follow-up visits in village center itself. They don't have to go up again. So any post-op and everything will be done in the village itself, and research opportunities for the institution. For the government, they get all the digital reports, and when they allocate the things, they can allocate based on evidence-based human resources and financial resources. So we can wait for 5G, so it'll be very helpful. Now, telemedicine hurdles. What are the problems? So very important is the internet connections, data limitations, smartphones, and then electricity problem. This is easily solved. So we put inverters and there's no problem with it. And then the problems is villagers accepting virtual physicians. So they are used to hand-holding. So this is one of the big hurdle what we have. We have to overcome that. And availability of trained medical staff in the village itself. So that's another hurdle. And training paramedical staff, which is not a big deal. So, but physical examination limitations are there. And I mentioned what we are doing to overcome that. Electronic health records has to be user-friendly, very, very important component. And integration of physical examination lab diagnostic tools into the electronic health record. Billing modules are important. So it is important for ourselves and to show the government how it costs so they can allocate the financial resources. And standalone, where there's no internet, we have to create electronic health records which can upload later on once the internet is available. So all rural interventions are electronically recorded. So in that, digital reports analyze for effectiveness of all interventions what we are doing. And we are working in with the doctors in US and here to do different health research projects, which and to be published in national and international. And we're working on that, and we will do it. So now set up. So then the final question is, how much does it cost? So for setting up a telemedicine clinic, it almost costs 3 lakhs, and monthly charges almost 51,000. So monthly charges are given by the patients. So, and then this setup, Soshodhan Trust is going to do, and later on, either through corporate social responsibility or if the government is interested, we can set up these clinics. And then, so as we mentioned, so it's an entrepreneurship. So there are 1 million villages. So each village, if you provide 100 jobs. So now you remember, not only we're working on digital telemedicine, we're also working on digital schools and also digital jobs. So like a computer village, computer center, I feel have strong confidence at least we can minimum we can create 100 jobs. The job potential in rural areas is 100 million jobs can be created. Economic benefits. So then 50 lakhs almost investments there. So I think probably out of which you can imagine 5 lakh crores. So this is a huge investments for potential investment and potential gains. Then we are not taking into account all the jobs and other economic things which are generated in mandals, districts, cities, and country. So this is the entrepreneurship as a startup what we spoke about, and now I've shown you what it is. So then, so is it possible? Yes. See, this is if you all think this is the picture from Mars. So where a rover is there, and then as you can see from what distance it has taken pictures, and these pictures are coming from the Mars. So it's so simple. The technology is there, so we all have to work together to create this, uh, to get this technology and put it into the telemedicine. So then the question comes, what cannot be done in healthcare using digital technology, especially with the coming of 5G? So the question is not what we can do, what cannot be done is the question. So this shows that. And now again to end my this thing. So yes, social interest is a social rural entrepreneurship. So the plan is to this. Now we have gone to the remote village, and once we set up this within 6 months, we have enough information. So we would like to set it up in all the villages of Adilabad, then Telangana, and possibly India. Model village, as I mentioned, vision replicate this, and now I'll rest my voice and I'll leave you all to answer any. I'm here to answer any of your questions and answers. Thank you for your time.
Thank you so much, Dr. Reddy. It was a really interesting, presentation that you have given, and in fact, we would like to talk more with you because we are trying to build a model to bring Ministry of Rural Development and the areas of RD to coordinate with health and how we can work here. And in fact, just before you, we had Dr. Pankaj Mathur, and we were talking about whether the women self-help groups can somehow be connected to this model that you are talking about, like setting up telehealth centers, etc. So all those possibilities we would like to discuss with you before we prepare the workshop outcome document. However, we would really like to move on to the next presenter and would like to take the questions combined at the end of the panel because the next presenter is already here, and let us have the questions at the end if that is okay with you.
Sure, Ms. Ruchira, that's fine.
Yeah, okay. Dr. Sambit, am I audible? I think I can.
Yes, Dr. J. Yes, you are audible.
Yeah, so I have already given you the presenter control, so you should be able to share your screen if you like. For our participants, let me quickly introduce Dr. Sambit Dash to you. He is a senior grade faculty and an assistant professor at Department of Biochemistry in Melaka Manipal Medical College. And he has written regularly in different columns in newspapers. If you are following The Wire, the Live Mail, etc., he writes his opinions regularly, so he is widely published. Dr. Sambit will be talking about, again, the experiences and possibilities and the challenges and solutions to telemedicine implementation in India from his own, work and experience. So over to you, Dr. Sambit. You may please take up from here.
Dr. Richa, thank you for that kind introduction, and thank you for the opportunity. Let me quickly share my screen. Yeah, could you please confirm that this is visible to everyone?
Yeah, the screen is visible. Can you please start the slideshow so that we can see it?
I already have. Is it fine? Is it now visible?
We can still see the file, but not the slideshow. Maybe if you share your whole screen instead of.
Okay, I will do that. I'll do that. Are we good now?
Yeah, it's visible.
Okay, perfect. So a very good morning to everyone present here. So what I'm going to do in the next 20 minutes, my allotted time, is to give both, if I can say, a 30,000 feet view, as well as some things that are on the ground. I'll admit that it's a tough act to follow after Dr. Reddy's fantastic presentation. But what I'll embark on in the next few minutes will be an amalgamation of uh, policy aspects, something that is of interest to NIRD. So let me focus on areas that are closer to my domain of education, medical education particularly. So look at this statement from a paper published in 2019, where this is about telemedicine in India. Where do we stand? This was 2019, and they have concluded with one of the statements. Despite having so much potential, still telemedicine has not attained the boom which it was meant to create. Perhaps everyone in this audience now knows that come 2020, come pandemic, and that boom, perhaps, which telemedicine was looking for, was given to it. If we put this in perspective about the growth of telemedicine, it is a market that grew sharply, as we can see, from 1.3 billion last year and is growing at a very fast rate of 40% year on year. So that gives us an idea of the growth that has happened. Now, what I intend to do in my talk is telemedicine, if we can very broadly divide it, has two parts to it, as this image is a representative of it. So there is a technology side and there is a human side to it. If we are to focus on the challenges, and that was the brief I was provided, the challenges of telemedicine. On the technology side, there are a host of issues, be it access from a infrastructure point of view, or equity, as we know that women have lesser number of, say, mobile phones in India, in rural India especially. Data privacy, a lot has been spoken about. It's a very major issue that needs to be addressed. We know that data protection bill has also undergone changes, and that is also another concern at a very broader level which will address the policy. But in this talk, I am not going to focus on these aspects. I will leave technology completely aside, perhaps because 20 minutes is too short to encompass everything. I will leave the technology part aside and I'll focus on the human side of it. And in that domain, I will talk broadly about four aspects. I have divided my talk into four broad groups. I'll talk about capacity, training, bridge, and policy. So let us go individually to these buckets and see what they are. Capacity. Now, we all know that the doctor-patient ratio in India is subpar of what is the WHO recommended one, but that doesn't complete the picture, and we'll come to that. So we do have a shortage of doctors, and that shortage is not uniform in the sense that there are subspecialty concerns. So for example, the total pool, whatever the ratio is, somewhere, if we are to take an average, somewhere around 1:1700, if you are to consider that. But that really doesn't paint the complete picture, because, say for example, number of oncologists in India, the number is very low. The ratio is really low. Number of psychiatrists, ratio is very low. So there are subspecialty concerns in that domain. Yes, in the recent years, because of the effort of the government, the number of medical colleges have increased. We now have around 648 medical colleges in India, with about 98,000 MBBS seats. So there has been a drastic growth in the number of seats over the years, and we will see that coming on ground, the changes in a few years' time. But as I said, the complete it doesn't give us the complete picture. As we know, the 70% of India's population residing in rural sector is catered to by 30% of doctors, and vice versa, 30% of population in urban areas are catered to by 70% of doctors. So you see, herein lies a major challenge, which is actually this workshop is addressing this particular challenge, that the challenges of telemedicine in rural India. And come pandemic, the boost that e-Sanjeevani, and I will focus a little more on e-Sanjeevani particularly. So post 25th of March 2021, when the guidelines for telemedicine were released, uh, there was a frantic activities going on in the domain of e-Sanjeevani. And today, and I have obtained this, these are recent figures of 8th November. So a large number of patients in, and please understand that these patient volume actually is majorly from rural India. About 87%, about 85 to 87% of this is coming from rural India. And we see that more than 200,000 doctors have been onboarded for this program. The wellness centers, about 106,000, has been operationalized with eSanjeevani, and the target is to meet the whole set of 150,000 by this year end. Now, eSanjeevani has brought in a lot of changes and has the potential, importantly, and has the potential. Let us understand that this is actually a newcomer, and in the small set of time that it has come into picture, it has really disrupted the telemedicine scenario. Now, again, when we talk about doctor-patient ratio, we are actually, as I have been telling, that we are not seeing the complete picture. There is also a distribution problem with specialists, and specialists are particularly concentrated in tier 1 and metropolitans. So what is the target? The target is to bring specialists to the rural setup, and telemedicine is going to bridge that. But however, there are some concerns. The concerns are, if I just logged into eSanjeevani this Sunday, and on a Sunday evening, we can see that this is the dashboard that is presented, that there are just 25 doctors attending at that point of time. And please understand, this is at an all India level. Now, there is also another concern. If we see the average consultation duration, and that has remained constant, this is not just referring to Sunday, the average remains in that period. The average consultation time remains to be very low. Now, the average consultation time in India is generally low. It's not just face-to-face, I mean, including face-to-face. So there are these challenges which perhaps going ahead needs to be addressed. In terms of capacity, and in the domain of telemedicine, there is a major difference between the private sector and the government sector. We spoke about, or we have been discussing eSanjeevani in the last couple of minutes. But the private sector had taken up to telemedicine much earlier in the game. As we know that Apollo has been a market leader in that. Perhaps the launch was when Bill Clinton arrived in India, in this village of Dr. Reddy. The telemedicine unit was set up, and it started from there. ISRO has been a leader. We did hear the first speaker elaborate about that. I'm not going to go into the history of it. What I want to focus on rather is talking about the challenges part. And please note that we will follow these things ahead with the other challenges. So it has been seen that the follow-ups, importantly, the follow-ups in private sector telemedicine and government telemedicine e-Sanjeevani, there have been a major difference. About in private sector, the follow-up rate is approximately about say 50%, whereas in e-Sanjeevani, the follow-up rate is about the half of it, nearly 25 to 27%. Why is it important? All of us know that it is healthcare is not a just one-time thing. There are challenges there also. This also takes me to the very important point that that someone made in the morning, Dr. Divya made in the morning, who is the nodal officer of telemedicine in Kerala. She made the point about the difference between direct consultation and the rest of it. And I guess herein comes a very important feature about differentiating. So all in all, the private sector telemedicine practices have been existent since some time, and it will do well if both of the sectors come together in working towards it. Let us really remember that e-Sanjeevani was put up during the pandemic because of a very good combination of both government sector, CDAC, Mohali working towards it, engineers there, plus in fact at that point of time they were not equipped to do it for cloud based services, and AWS, Amazon Web Service engineers did come in to help this make it a cloud initiative. So I guess going forward also there needs to be much more participation at both levels to bring the best of both worlds. I'll now next move to training. And here I want to emphasize that right in the middle of pandemic, the American medical education system brought about, and this is not new for them, the talk has been happening since some time, but competencies for telehealth. And what do I mean by it? I'll elaborate. Now, the Indian medical education currently does not have any emphasis on telemedicine. It is very important that with the growth of telemedicine happening and with the potential that it has to address health issues in India, we inculcate these things right in the medical curriculum. So both at undergraduate level and postgraduate level, competencies addressing telemedicine has to be included in the curriculum. Why I say this? The reason is this is very important for us to understand that the competencies required for telemedicine are little different than that of regular face-to-face medicine. The new age tech training that is required, one thing. The ethical aspects that are associated with it, or very simply, the bedside manners which are normally taught, the bedside competencies are different, are in fact will be quite different than that of what will be teleside or what we can say webside. Please imagine the communication that happens between the doctor and patient when they're face to face, when there is physical examination going, will be pretty different than how it will be in the teleside and website. And this is just a generic statement. Please understand that this will again vary from specialty to specialty. So this has to be a formal affair. We cannot or must not expect our doctors to learn this on the go. This has to be institutionalized, and in that process, this has to become much more detailed. Now, we are all aware that there are certain specialties which say it is more like they take to telemedicine more easily. They are built rather for it. Say, a lot was discussed about ophthalmology. Ophthalmology and with the application of artificial intelligence has tremendous potential. Dermatology, radiology. So certain specialties have greater potential to telemedicine, and therefore those specialties must make it must make it their mission to create more subspecialty specific guidelines. It exists in the US. in the US, these separate specialties have their own telemedicine guidelines which are specific to them. Mental health, another very important area which telemedicine has a lot of potential to address. So these specialties must come up, the professional bodies that are there in India, they must come up with their own set of guidelines, which will ultimately feed into the competencies in medical education, both at undergraduate and postgraduate level. This, I believe, is very important. There was a report in the Ken where they spoke to someone in UP, the intermediary, the very important intermediary, and I would like to spend some time here. So the person said there are poor illiterate patients who have no idea how to use the app. So the state has pivoted towards a model where the community health officer like me connects them to doctors sitting in district hospitals or medical colleges. So anyway, the person goes on to say that there are good days, bad days, there are connection issues, etc. That's a separate debate altogether. But this has been one of my focus areas since a long time, that bridge is very important. We all know that the telemedicine system in India or anywhere else focuses, or rather operates on a hub and spoke model, right? There's a hub and there are spokes, but there is a bridge that joins the hub and spoke, and that, I believe, is a very important factor, and it is also a factor which must be very close to Ministry of Rural Development. Actually, let us see what they are. The importance of mid-level healthcare worker cannot be more emphasized. It is absolutely essential that if we are to see greater adoption of telemedicine, if we are to see more successful adoption of telemedicine, there needs to be a cadre of mid-level healthcare workers. Now, they come in different shapes and forms. We will discuss that. When we also go to the next area of policy, we will again come back to this. For the primary care aspect, mid-level healthcare worker is essential. Many states have tried this model. One of that would be, say, if I'm to cite an example, Chhattisgarh, for example. Chhattisgarh has the rural medical practitioners. So it's this mid-level healthcare worker is drawn, say, locally, is actually again not a MBBS doctor, but is trained to bridge the gap. Now, why is this important? And this also takes us to the very example that Dr. Reddy was talking about. And this shows that why this is important. And for this to really work, I would say that the first point should be to move from that fixed mindset where we would want that all the PHCs, CHCs are filled with doctors from top to bottom. So perhaps we need to look at a model where the mid-level healthcare worker plays the important role. And let me tell you that research has shown, and especially in this Chhattisgarh context, let me tell you that study was carried out between the non-medical healthcare worker in the rural setting, and there was absolutely no difference in their knowledge level or in their way of dealing with primary care. It was perfectly fine. So with repeated training, definitely this model sustains. Now, why are mid-level healthcare workers also important and in context of telemedicine? India has a huge non-communicable disease burden. We all know that. It is very important that we place mid-level healthcare worker in that setting with, please note, this doesn't come separately. And I have to mention at this point that we cannot perhaps overburden the ASHA worker with more and more stuff to do. we may perhaps increase the number, increase their capacity as such, and then add on. But with the monetary remuneration that they receive normally, and the amount of work that they do, just burdening them with this further is perhaps not going to really work. We spoke about follow-up a little while ago. Lower follow-up was seen in e-Sanjeevani case, of course, given the benefit of doubt that it is new on the block. But this follow-up is important, and because medicine is not just about going one time and then finishing it, but it is a relation between the healthcare provider and the patient. And who better than the mid-level healthcare worker who is present in the setting, is drawn from the local community, has a touch with the people in the smallest subset possible. That would be the best way to go about it. Who then can facilitate this follow-up? It can be a very simple thing. For example, somebody has just gotten on antihypertensive drugs. You need to see after a month or so how he or she is doing. It should be the mid-level healthcare worker who should be able to help there. Because otherwise what happens is then cases fall through the cracks. The personal touch, and I want to cite this one small example which would be of interest to NIRD and MORD, that for example, one of these successful cases of the movement, the SHG movement, is Odisha, where about there are 70 lakh in last year 2020 2021. The mission Shakti in Odisha has been successful. So these are models, successful models, on which definitely telemedicine can bank on or can get on, and that would be a that would be a good model to work in a smaller rural setup. So this is about that bridge, and I really believe that this is very important if telemedicine is to succeed. Coming to the last bit about policy. Now, I will not spend too much time on this, but very quickly brush through this. So the regulation of telemedicine has to go hand in hand as it progresses, and this is the right time. For example, now there is ISO certification, which perhaps only Apollo has as of now. It should be made incumbent on all the hubs that are providing telemedicine services to be accredited. It is important. Or the government could come up with their own scheme of things. We understand that health falls under the state list, but during the pandemic, we have seen a lot of admixture happening. And when I said state list, I go back to my point on the bridge that is required for successful telemedicine operation. States must take it on them and draw from the good examples that we have. For example, the Chhattisgarh's example of the mid-level healthcare worker, to create that cadre, whatever works best for them. Odisha might decide to do it with the SHG groups, just for example, or create a cadre. So all states must brainstorm about which would be an ideal model, and of course evidence backed, about which telemedicine can ride. And only through this evidence based informed policy making will the adoption and penetration increase. currently, uh, it eSanjeevani has shown tremendous potential, and it is important that we raise its adoption and penetration. We all can imagine that the positive externalities of such moves are plenty. It is not just restricted to providing a telemedicine consultation, but the positive externalities then spill over into various areas. So policy making at this stage is very crucial, which must be backed by evidence, because we are just 1 or 2 years into this boom, and going forward this will set the whole process in a particular manner. I will just cite one example. I'll not go into the details of this. Perhaps I am close to hitting my 20 minutes mark. So I'll just cite the example of Andhra Pradesh. Reason being, uh, nearly half the all e-Sanjeevani consultations that has happened are from Andhra Pradesh. Actually, 43.7% of the 3 crore consultations. Now, very briefly, if we see the structure, they did come, with some prior experience through their MSS app, which was meant for women and child, or the YSR telemedicine, which was rolled during the pandemic, early days of pandemic. The number of doctors present were higher. They were trained in that regard. So they very quickly moved to all the medical colleges being hubs. They quickly connected all the PHCs and SSCs there, and they maintained a balance of the specialists. 2 MOs were there in each of these units in the hubs, and importantly, if you can see there, they also got the ASHA workers, though it worked for them in the longer run. I don't know, it is working well. So about 42,000 ASHA workers were given smartphone on which they then linked the patients. They had 3 rounds of survey during the COVID pandemic, video conferencing, and even going to the last mile. And that last mile is very important, as we all know. Last mile, the doorstep medicine delivery, or where it was not accessible, the MO used to visit where it was required. So there are models which have shown promise. We must draw from these examples to create best practices in telemedicine. I'll very quickly close with road ahead. The road ahead holds a lot of potential. As we just heard Dr. Reddy, the tech is available. We need to bring it. Going forward, I see that telemedicine then further branches to remote health monitoring with devices, non-invasive. Very importantly, patient education. I believe that eSanjeevani is a very good platform which can actually onboard patient education on it. ICU monitoring, very much, again, Dr. Reddy mentioned this, ICU monitoring in rural setups will be a thing. And as the trend goes that people visiting hospitals for smaller ailments will reduce, and it will be only for major interventions that people go to hospitals, the avenues of telemedicine must not be restricted actually to PHCs, CHCs, I believe, and should actually go on further to go to schools. I mean, why can't actually there be a booth in each schools where a child, and for example, an adolescent girl having issues can just call up and get the queries. There should be a safe space in schools where this can be provided. Going forward in colleges, workplaces, and so on. Further, uh, again, that last mile delivery will be through drones gradually, and we are now also aware that, and with decreasing cost gradually, AR, VR, or metaverse will be an experience that can definitely be taken to rural areas. We just have to bring right people together. The technology exists, the technology is growing tremendously fast, and only through right policy formulations can we arrive in a proper way at that point. I guess I'll close my talk with this. Thank you for the opportunity.
Thank you so much, Dr. Sambit. It was an excellent presentation, and you have brought all these areas with such great detail. We would really like to continue this discussion with you, and I hope we can talk more about this, because there are a lot of potential to bring the self-help groups on board in this initiative. And of course, as you know, self-help groups don't get any kind of remuneration or salary or any kind of honorarium as the ASHA workers get. But still, if there is a possibility for them to set up a business model at the rural areas to kind of be that second line worker between the formal health institutions and the community, we would really like to talk about the possibility of that, whether that model can be built or not. Also, you were talking about unburdening of the ASHA workers. I think there is also tremendous potential if we kind of extend this work among the self-help groups. Then unburdening might also happen with other members of community joining it. And there is also something that I would like to know, because I hope that you are staying on even after the panel discussion, because we'll have a combined interaction session later. Because I also, and this is also to Dr. Reddy earlier, because I want to know that what is the possibility. We talk about removing the quacks from the system, but can we train the quacks and bring them onto the system? So what is the possibility of that? Are there any previous experiences on doing that? Because this is also kind of I don't know, a human resource you have at the community. Can we somehow train them and connect them to the system formally, rather than having completely or no control over this group of people who are providing healthcare, although wrong, but still they are providing, and people are depending on these people, group of people for health providing. So these discussions will continue, but let me invite our next presenter and distinguished panelist. Dr. Ganapati, am I audible to you?
Yes, please. Can you hear me?
Yes, sir. You are audible. I have given you the host control, sir, so you can share your screen if you want to. For our participants, let me quickly introduce Dr. Ganapati. He is MCH Neurosurgery from Apollo Telemedicine Networking Foundation. He is also director of Apollo Telemedicine Networking Foundation and Apollo Telehealth Services. He was a president of Telemedicine Society of India, Neurological Society of India, and Indian Society for Stereotactic and Functional Neurosurgery. He is distinguished professor in the Tamil Nadu Dr. MGR Medical University. He is an emeritus professor at National Academy of Medical Sciences and also WHO digital health expert. He was formerly adjunct professor at IIT Madras and Anna University Madras. We are very happy to have you with us today, sir, and the session is now over to you. We have nearly 50 functionaries from different states. These are nominated health functionaries and telemedicine consultants from the state health missions, and also some of the NGOs who work with the communities on health. Over to you, sir.
Can you see my slide?
Not yet, sir. I think there is a lag in the network.
No, I don't know.
I think he is disconnected. Give us a few minutes before he joins. Sir, kindly unmute yourself. Dr. Ganapati, you are muted. Kindly unmute yourself.
No, I know I'm trying to some problem here. Okay, can you see my slides now? Can you hear me?
Yes, sir, you are audible. We are waiting for the screen
Yeah, I
share.
know. Can you? I don't know, some problem with I'm not getting the share. That's not enabling. It only says cancel. Can you enable that? I don't know what's happening.
We have added you as a co-host. So are you
No,
getting?
but no, I'm not able to enable. The share is off.
You are not getting the present now option.
Okay, I think now.
Box with an arrow in it. Yeah, yeah, yeah. Now we can see your screens.
You are able to see the screen.
Yeah.
I don't. I'm still not able to get it.
If you open your PowerPoint, we can see the Google Meet. But if you open the
Yeah.
PowerPoint,
Can you see it now?
and just go to
Yeah. Can you see it now?
yes, it's visible now. It's visible.
Okay. The first slide, rural telehealthcare, the Apollo story. Can you see it?
Yes, yes, it's visible.
Okay, first of all, I'm sorry for this technical problem.
No
First of
issues.
all, I want to thank the National Institute of Rural Development for this excellent method of trying to sensitize people and create awareness. This is very, very important. Now, I'm not going to bother about numbers. All of us know, not in the lifetime of my great grandchildren will there be enough brick and mortar hospitals for 70% of India's population living in rural areas. These numbers are not very important, but what is important is the fact that simultaneously a billion people already have phones and more than 450 of them have smartphones. Internet penetration has reached an all-time high. What exactly do you mean by the word telemedicine? Telemedicine is not just video conferencing or a telephone call. Ideally, telemedicine should include hardware, software, connectivity, acquisition of images, storage of images, the ability to retrieve and digitally manipulate these images. Technology is changing every day, and therefore, we require constant training, retraining, learning, unlearning, and so on. One size does not fit all. Customization is the name of the game. Everything has to be contextual, and today we need to be compliant with regulations. I have always maintained in the last 22 years, I am not a hypocrite, and let's face facts. What is in it for me? You have heard of Wi Fi, you have heard of WiMAX. I coin a term which I say YFM. What is in it for me? Unless there is something for every stakeholder in the ecosystem, telemedicine is never going to really take off. It was on March 24, 2000 that the first village in the whole world was enabled with a VSAT. ISRO, Indian Space Research Organization, with whom the Apollo hospitals collaborated, in commissioned by Bill Clinton when he visited India. And today, 22 years later, of course, the role of VSATs has considerably become less because of the penetration of terrestrial internet technology. Nevertheless, VSATs continue to play a role in extremely remote areas. I'm going to show you a few clinical examples which you can relate to. The next 20 minutes, I'm not going to talk about theory, but I'm going to show to you that India, unfortunately, suffers from a disease called pilotitis. We always talk of pilot projects, we talk of proof of concept validation. I will show you with enough numbers. Today, we do almost 20,000 e-transactions every single working day. But what is required is not one Apollo Telemedicine Foundation. What is required? 1,000 of them. We have shown that it is eminently possible and doable. And it is workshops like this which would stimulate others to replicate, duplicate, and not make all the mistakes we made. Here is a simple example of an ordinary entry level phone, a person who had suffered a severe brain injury, now back in his village. As a clinician, I obviously need to know how he is. And you can see how, from the comfort of their own home, I'm able to do a detailed neurological examination. Now, this, I hope the video works here. Now, this is seizures, convulsions. As you know, most people with convulsions on examination do not have a neurological deficit. But just look at this, an ordinary mobile phone, even a medical student, even a lay person will be able to see that there is something wrong with this boy, the way he is looking. And if you look for another few seconds, you'll be able to see saliva coming out of his mouth. This is all that a doctor needs. I can make a specific diagnosis of a seizure disorder. This is the power of telemedicine. Distance today has become meaningless. geography has become history. I have personally done about 4,000 teleconsultations in neurology and neurosurgery, which is my specialty. I'm just showing you a few samples from remotest part. This was at the height of the pandemic in Himachal Pradesh, and you can see this gentleman, a very elderly gentleman, 80 years old, has been operated, and post-operative evaluation I am able to do from the comfort of my house in Madras with this person in a very remote village. This is in the Himalayas at a height of 14,000 feet. My dermatologist, he was able to prevent an epidemic taking place in the monasteries of Kaza and Keelong in Lahul and Spiti at a height of 14,000 feet. He was able to show, you can see all that is required is good internet connection, a reasonably good camera, and he persuaded all the monasteries. He said this is highly infective, and so we sent one of our staff to all the monasteries, and we were able to pick up a fungal condition on the scalp even before they became symptomatic. This is the power of telemedicine. Dermatology, of course, with a 99.5% accuracy rate. I think it's a crime today to make anybody come back to Madras, Delhi, Bombay, Bangalore, Ahmedabad, the big cities, just for a post-operative review. You can see this child has come from Nagaland, and today with the camera, the cardiac surgeon is able to see the scar with a stethoscope. We ask the family member to place a stethoscope on the chest of the patient, and the doctor is able to hear the heart sounds and the lung sounds. If you look at the photograph on the bottom, you'll see a date stamp, 2001. Long before the rest of the world had even thought of tele-echocardiography, our pediatric cardiologist was evaluating echocardiograms from tier 3 cities and towns. And on the right-hand side, you can see an echocardiogram actually being transmitted. The COVID, of course, has totally changed the perception of technology-enabled remote healthcare. In a recently submitted paper, we showed LMIC, lower middle income countries, and you can just see the huge numbers here. This is what the Apollo Hospital Group, 71 hospitals, did. Somehow there is an erroneous perception that all corporate hospitals only cater to the urban elite. They're all dividend declaring companies. Nothing can be farther from the truth, especially after the COVID. Today, most corporate hospitals look at public health, and by sheer numbers, we know there is a greater market in rural India than there is in urban India. Vaccinations alone, you can see 5 million vaccinations were given, a good majority of which were from remote areas in tier 2, tier 3 cities. So this was all using technology. We set up emergency tele-ICU units actually for the National Thermal Power Corporation, a Government of India public sector undertaking, in some of the remotest parts of India, Indo-China border, in Assam, in the Thar Desert. All this was set up within 10 days. My staff went everywhere, and we were able to handle the COVID management for most of the factories in India. So this is the power of telemedicine. Now, since this entire workshop is about rural telehealth, let me give you solid examples on how, for the last 7 years, a corporate hospital group has literally, virtually gone into the remotest part of the country. Papers have been published in peer-reviewed index journals. Chapters have been written in textbooks. And I'm very happy that today this is used as a benchmark, including by the Government of India when it is promoting public-private partnerships. At a temperature of minus 25 degrees centigrade, my staff are there. We are able to pick up heart attacks while they're evolving, and my staff in Chennai instruct a paramedic there on how to initiate thrombolysis. We have real-time dashboards. I can tell you exactly what happened half an hour ago by logging on to the link. You can see on the top right, we have done about 25,000 patients we have seen in the last 5 years in the remotest village, and we run the world's only 24/7 tele-emergency services, 1,359 teleconsultations have taken place in the last 5 years, and we have saved at least 23 myocardial infarctions even as it was evolving. All this is only done with a dedicated program management approach. The first thing we do is we go to the villages. In the earlier years, I used to do this personally. Now, of course, the younger staff does this. I have gone to at least about 150 to 200 villages across the length and breadth of India. We talk to the beneficiaries. We do a detailed need assessment. We train, retrain, untrain, and things like that. Of course, we have joint management committee reviews, MIS, impact assessment study, and of course, most important, we have what we call an exit plan. Meaning, we tell the government we will do everything for you, and then after 3 years or 5 years, we hand it over to you, we take over. Just look at this real-time dashboard as on 7th November. If I had not been a little lazy, I could have done this even half an hour ago, and I could have presented to you a slide 30 minutes ago. You can see the laboratory investigations, 3,44,150 laboratory investigations. Please remember that these quality control for all these lab investigations are done from Hyderabad, Chennai, and other parts. In fact, everything is tele. Everything is remote. We believe the geography has become history. This is the Uttar Pradesh telemedicine dashboard. We have major public-private partnerships with Chhattisgarh, Jharkhand, Uttar Pradesh, Andhra Pradesh, Telangana, and so on. So these numbers speak for themselves. For lack of time, I'm not going into the details. This is again the world's largest rural tele-ophthalmology project. Day before yesterday, we had completed 23 million eye checkups. Of this, almost 450,000, 500,000 fundus examinations were done by 35 ophthalmologists sitting in Chennai. We have, as you can see here, 13 districts of Andhra Pradesh, and in 13 districts of Andhra Pradesh, there are 115 tele-ophthalmology centers. These centers originally were the government of Andhra Pradesh, but then through a tender, through a contract, they outsourced it to us, and the Apollo Telemedicine Department runs this completely. Where in the world will you get a color printout with a turnaround time of 20 minutes? Within 20 minutes of the poorest to the poor, below poverty line, getting into one of the teleophthalmology units in one of the districts in Andhra Pradesh, my ophthalmologist, using semi-automated software, gives a report, sends it, a printout is taken and handed over to the patient with a turnaround time of 20 minutes. And all this is done totally free for the patient. We get a contract, and because of excellent business management, we ensure that our expenses are slightly less than the income we get. I need to reiterate that the telemedicine department of the Apollo Group is a not-for-profit foundation, unlike the other departments, and we ensure that there is just enough income to manage our expenditure. This is Meghalaya Digital Dispensary, Jharkhand, etc. I am a scientist by training, and I believe that data is required, evidence. There is no way I can convince even the government that this is worthwhile doing unless I show that it is economically viable and feasible. We have published chapters in books where digital healthcare in public-private partnership mode, and one of our most important papers was to show the economic viability of technology-enabled remote healthcare. We showed that when you outsource it to a private organization, we are able to do 3 times the number of tests which are available in primary health centers. We started HbA1c in a primary health center. Today we do electrolytes, calcium, magnesium, etc. in a primary health center, the 230 primary health centers which are running. And most important, the laboratory test costs just less than a third of that in private laboratory. We also showed that over a 4-year period, the government spends $1.50 to get a neurosurgical opinion, a cardiologist opinion, a super specialist opinion. Where in the world will you get a super specialist for $1.50, 24/7 around? We are doing all this, but I'm very, very unhappy that this is still isolated here and there. What conferences like this need to do is to convince everybody that this is doable, and I think it is time, and I think your institution can play a very major role in ensuring that telehealth becomes an integral part of the healthcare delivery system. Again, the Apollo Hospitals is convinced that health is not diagnosis and treatment, and we have one of the biggest corporate social responsibility programs in the world. More than 75,000 people living in this village of Aruganda, the birthplace of Dr. Pratap Reddy, the founder of the Apollo Group. From from the moment they are born till even after they die, the entire family is looked after. You can see here, it is mental wellness, physical wellness, everything, schools, colleges, health initiative, total health is what we call. This is what is done. Again, through a major CSR activity, unfortunately, because of the COVID, this had to be stopped. We have done 1.2 million screenings. We have had screening for diabetes, obesity, hypertension, and so on and so forth using technology. And this is one of our very big projects. What India requires today is 1,000 of such centers. This is one of the biggest centers in Hyderabad, Apollo Hyderabad, the remote healthcare division. At any given time, we have about 250 people, a medical response center available 24/7. But one center like this is not in Norton. I am absolutely delighted that the Ayushman Bharat is talking of wellness. They are talking of health and wellness center, and they have already sanctioned 150,000 telemedicine units for all the proposed 150,000 health and wellness centers. The National Digital Health Mission, the very word digital health, very clearly shows that the future of India lies entirely on digitization. I could go on and on, but I would like to spend the last couple of minutes on saying that prevention is better than healthcare. And this is something which most medical doctors are not really embracing. We started this about 8 years ago, but unfortunately, due to absolute lack of funding, we had to stop it. With the MS Swaminathan Research Foundation, Professor MS Swaminathan is well known all over the world. Through his research foundation, we adopted 25 villages, and every 2 weeks, one of my consultants would give a talk. We have touched more than 22,000 villages. 100 fortnightly sessions have been held so far. And now, of course, unfortunately, we have stopped it. We hope we are able to revive it. These are all the various villages which have been covered. We also have developed a hybrid method where, like the ASHA, you have people who are specially trained, go to the remote villages, connect them to our specialists. I myself have given about 8 to 9 talks on various aspects, head injuries, brain tumors, headache, back pain, that, this, etc., in the local language. And one of my representatives there represents us and also asks questions and patches these questions to us when required. I was very happy that the previous speaker had mentioned drones, and with the World Economic Forum, the Niti Aayog, a paper was just published 2 months ago. We have completed pilot projects, proof of concept validation. The government of India has taken phenomenal steps in trying to make regulations very, very reasonable, much easier than what it was before. And I hope that next year we will start using drones to provide not only vaccines, drugs, blood transfusion, and so on and so forth. We need to be future ready. It is not an empty boast that 5G is going to come. I'm absolutely certain that in my lifetime, I'm going to see 5G in the tier 2 towns, if not in the villages. We already have tied up with Cisco and Bharati Airtel. We have several ambulances now, pre-hospital management before the patient comes to the hospital. This is the future, and this is what is going to be done. Ladies and gentlemen, I would like to conclude by showing this slide. I think this says it all. India is very well known for Jugaad. I think innovation really starts in India. In one of the remotest parts of called Tuver, a village about 250 miles away from Ahmedabad, For the last 3 years, we are running a project funded by the University of Pittsburgh. They give us about $150,000 a year, and you can see these poorest to the poor, below poverty line, they hired a bullock cart, and they gave, I understand, they gave 200 rupees for a round trip. This 200 rupees was shared by 10 or 12 people, and these people consulted the same dermatologists, the same physicians, the same respiratory physicians, cardiologists who treat the urban elite in Chennai. The same consultation was given free of cost. Medicines were also given free of cost. It is my dream that in a few years from now, instead of coming in bullock carts, they will probably come in a locally made e-scooter, an electronic scooter. And as you can see the figure on the right, a tablet, a phablet as it is going to be called, a phone combined with a tablet, will be available for less than 3,000, 4,000 rupees. And this is what is going to happen in the next couple of years. So these are all the numbers for the 2-year program. Finally, where are we going to get the doctors from? Where are we going to get healthcare providers from? In 2014, I had written a paper in the British Medical Journal, which had a tremendous reception outside India, but unfortunately, I just don't have the contacts or the necessary people. I am absolutely convinced, particularly now, that a virtual rural healthcare service is the answer for India. This has been tried not virtual, a compulsory, mandatory rural healthcare service for interns, postgraduates has been tried for the last 20 years and given up because the doctors protested that I cannot spend 2 years of my best part of my life in a village. But none of us will ever resist the idea, and people, particularly people who are 60 plus, 70 plus, etc., who are still physically and mentally absolutely fine, we will be delighted to give 1 to 2 hours every day virtually going to the remotest village of India. This is so easy to do today, eminently doable, but for some reason this is not happening. Virtual rural healthcare service, mandatory, compulsory, use a stick, use a carrot, and also carrot and a stick. I think this is the answer. Ladies and gentlemen, India is the most amazing country in the world. Where will you see a 96-year-old woman becoming digitally literate? Where will you see thousands of senior citizens, particularly more women than men, in the remotest part of India today handling smartphones? If this is India, the real India, thou shalt digitally transform. If Moses were to come back to India, not to India, sorry, if Moses were to come back to the earth and give the 10 commandments, every single commandment should be we have the prefix, thou shalt digitally transform. The only way we can hope to bridge the urban-rural healthcare divide is to digitally transform. And let us never forget that rural India, people in rural India also have brain tumors. They also require cardiac stenting. They also require cosmetic surgery. And so from a physical and mental point of view, from a healthcare point of view, there should be no difference at all between rural India and urban India. Today, it is possible for every one of us to be virtually be present in rural India. But what is required are organizations like yours. You and you alone can be the torchbearer. You have to convince everybody that this is doable. We have enough data, enough proof. But what is required now is to ensure that this is not one Apollo Telemedicine Foundation, but hundreds of them. And I'm sure I'm speaking for the leadership of the Apollo Group. We would be very happy to cooperate, to collaborate, and to talk to every one of you so that you do not make the mistakes which we have made over the last 22 years. Thank you once again. If there are any questions, I'll be happy to take them.
Thank you so much, Dr. Ganapati. Such a note of hope and an address to the participants here. With that, we have concluded our panel discussion. The floor is now open for questions. And as we have said, that the question and answer session will be combined for all 3 panelists. So I request our participants to please unmute and ask your questions. And you can also raise your hand and we will unmute you to ask them. A few questions in the inbox which I had missed earlier, but let me just read it out at the moment because just noted them later on. First is the question from Akanksha, asking that how she can work out telemedicine in the rural areas of Himachal Pradesh, which loses the connectivity during the winter because of snow. And people are facing challenges during winters and losing connectivity with internet, and there is no signal to even call. And in the same line, Dr. V.K. Goyal also asks that there are many areas in Himachal which do not have landline connectivity, and there is no provision for net connectivity via any mode. So, how can telemedicine reach in these kinds of areas? So, this is an open question to all of our three panelists, and we would like to have their inputs individually on that, starting from maybe Dr. Ganpati and then me.
I will respond to that. We have 4 telemedicine centers in various parts of Himachal Pradesh. You are absolutely, we have been doing this for 7 years now. You are absolutely right. Connectivity is a major problem, and I don't think it's going to be solved very soon. So what we did was, and also there are security concerns because of the location of Himachal Pradesh. So we approached at the highest level. We spoke to the CMD. I personally spoke to the CMD of BSNL at that time, and we were able to get at a reduced rate because it was for a CSR activity. We were able to get VSATs. So, but I understand that in the next couple of years there are plans to increase connectivity. At the moment, VSATs are being used by us in all our 4 telemedicine centers. Number one. Number two, we need to be realistic. I mean, instead of a patient coming to Shimla or going to the near or go to Chandigarh or to the nearest place, there's no other way. Let them come to one of these 4 telemedicine centers are fairly equitably distributed. So within about 3 to 4 hours maximum, they will be able to reach these 4 telemedicine centers. We are also hoping that the Himachal Pradesh government will have more telemedicine centers. So once they reach one of these telemedicine centers, it's almost like reaching a secondary, tertiary care hospital. Answer to your question is the problem is not going to be solved. VSAT is the only answer at this point of time.
Thank you, Dr. Ganapati. Dr. Reddy, will you have some inputs to this question?
So the thing is, I do not have any practical experience like what Dr. Ganapati has got, but talking to the people and being involved in all this stuff, this whole program started with ISRO. I did have a chance to talk to ISRO. That may be an answer because the army people are providing the same services in remote areas. That's what ISRO started off the whole thing actually. So then they are providing this, and there's another DRDO. So there are two areas where these people are working. One is ISRO and the other one is DRDO. ISRO is completely confined. Initially, they wanted to spread all over the country, but currently they are confined only to the border areas and in mountain areas where that lady is questioning. So you might have to approach them. And hopefully the Indian government has got the heart of opening this up also. But they have this security issues, I heard. So where because they are providing special links to ISRO, that is one of the concerns they have. The second thing is DRDO. So they can approach the DRDO is currently providing, the doctors are providing only to the people who are in navies, like these ships and all those stuff. So I think probably the solution is if the lady is really interested, I've already approached Dr. Rayappa is the person who is in Bangalore. He's the person who takes care of ISRO. So because people are very busy, sometimes I think there is a lot of inertia in the movement and people may lose interest. But hopefully, if I talk to him and if that probably if I have a solution, I'll tell her also.
Right.
Can I just make one more remark?
Yes, sir, please.
See, unfortunately, in the real world, connectivity, though important, is only one of the issues. Please understand that you require a medically qualified person. Even if you give me all the connectivity in the world, you require a doctor who is available all the time. And let us be very frank. I mean, philanthropy is fine. Doctors can give free consultations up to a point. Therefore, the most important thing is it has to be revenue generating. Only if it is revenue generating, somebody has to pick up the bill. Unless it is revenue generating, you cannot expect philanthropy to provide teleconsultations for the rest of your life. It could be insurance, it could be government insurance, it could be state government sponsor, but somebody has to pick up the bill, and every single player in the ecosystem has to be compensated.
Totally agree with Dr. Ganapati. It has, as I showed up in my model, it should be self-sufficient, self-sustaining. So that's what Dr. Ganapati is mentioning. I totally agree with.
Absolutely.
It has to be self-sustaining. And I think probably we should stop depending on the government. I think the villagers who are benefiting should be in a position to pay. And actually, we formed a village society development committee. It's very important. Villagers have to participate in this. And unfortunately, I'm so sorry to say, we cannot depend on government. And the villages can pay. So as I showed you in my module, instead of paying 600 to 1000 rupees there outside, so why can't they pay 110 rupees?
Yes, exactly, sir. And we were also thinking that it can be a good business model for the community groups as well, or the panchayat may kind of take it up and set up the centers. I would also like to know that can the state officers forward a proposal on this in this regard? Like, can they take up the proposal to ISRO or DRDO directly, or does it have to go from the community?
I do not have enough an experience. I think probably during the next meeting, Dr. Murthy Ramella, he is the General Secretary of TSI. There is an organization called Telemedicine Society of India, which is framing all the policies. And I'm so happy, Sambit, I'm not sure how much Dr. Sambit, how much is in contact with these people. They're working actively in framing all these rules and policies. So probably, and it needs membership, and they're also looking for encouraging this. They're also kind of frustrated. Hey, this is, we can do so much with this. As I ended my talk, what cannot we do with telemedicine? And this is the futuristic medicine, as Sambit and Dr. Ganapathy has shown that also. And I can imagine their frustrations when they have the information. Why is it not reaching the common man?
Right.
I think
Dr. Sambit, let us have your input on that. I can see your hand is raised.
Yeah, I just want to make a very small comment on the connectivity part. So a lot in tech space is happening on that front. For example, we know that the broadband that we get is from the geostationary satellites, but many of us must have heard about Tesla's Starlink, which provides the internet. Those are at they fly at the lower height of 550 to 600 kilometers. So perhaps this movement which is happening, the Starlink, and they have a tie-up with the Indian this thing also. So Starlink India. Once that is operational, this I'm sure this problem of remote area internet will be addressed. Small
Right,
point.
right. But these are macro policy and macro issues. I mean, I don't know at community level how much we can get into that. My main question was, what can this Panchayati Raj or the community groups do, which can be a quick proposal from us to the MRD to kind of onboard on the telemedicine this thing.
Why do you think, Ruchiraji, why can't you do it? So we have to start somewhere. We shouldn't think it's a high project. Starlink, is like as Sambit sir has mentioned, has been proved in Ukrainian war. They already served it. The technology is there, but our approach to them should be big. No, why can't we approach them?
Right.
So very small point to add. In policy, as we say, changes happens on the margins. So perhaps also like Dr. Reddy was saying, or like Dr. Ganapathy was saying, if they have to travel to Shimla, at least find out which is the lesser distance to travel and start from there.
Right. We have another question in the inbox. Rushikesh is asking, is there any telemedicine centers open for persons with disabilities in India? And Dr. Javaretina Ji, she's asking, which are the specialities that are suitable for treating patients through telemedicine services? I think Dr. Ganapathy has already addressed Dr. Javaretina's question, but I would also like to have the input from other backgrounds.
I'll take the second question first. It is entirely contextual. Now, sitting in Chennai, having access to almost state-of-the-art resources with 22 years experience in telemedicine, me and my colleagues probably can handle a lot of teleconsultations in various specialties. I can peer into the interior of the stomach by somebody 10,000 kilometers away. So teleendoscopy is possible. Tell you this, everything is possible. However, in the real world, see, that is more important. It is entirely clinical. You require clinical judgment, clinical wisdom. I belong to the 20th century. So I would still like to do a rectal examination to find out if the prostate is enlarged or not. However, my student has been trained in a 4D ultrasound, and he may be quite comfortable looking at a 4D ultrasound of a prostate. So it depends entirely on the context. The single most important word is contextual. Having said that, common sense tells you that you do not use technology in when somebody's got severe pain, and I think the clinical diagnosis is acute appendicitis. I should not be wasting my time trying that there's an audio break and a video break. I should say go to a hospital. Err on the side of caution. Don't stand on your ego, and the slightest doubt you have, the slightest concern you have, please stop the teleconsultation and let him go to an individual physically.
Right. I think the this kind of sensitization and awareness of the officials who will be dealing with the telemedicine centers is also necessary. Where to
Okay,
stop?
the previous question regarding disability, I personally am against specialty telemedicine centers. Okay, I think the word disability is politically incorrect. The correct political word is less than able and challenge. So we should not have a separate center for disability. Every telemedicine center ideally should be done in such a way that a challenged person, physically challenged person, is able to have access to it. Today, the world has changed completely. Particularly for so-called less than able to person, the doctor goes to the doctor or the tele rehab specialist or whoever is the appropriate domain expert can go to where the patient is. I mean, it doesn't make sense to put somebody on a wheelchair and make him go 20 miles to the nearest telemedicine center. All I require today is a good phone. I don't require 5G, 4G, nothing. All I want is 1 Mbps speed. I don't want 300 Mbps speed. So it's all, again, as I said, contextual and the enthusiasm of the doctor. So the doctor today should go to wherever a so-called physically challenged person is located.
So if
Thank
I
you,
can,
sir.
if I can add something, Dr. Ruchira, it depends upon your aim. Telemedicine depends upon where you want to give the point of care. So, like as Dr. Sambit mentioned, so we
10 minutes
are
complete.
working in rural
Watch it.
areas.
Oh,
So
good.
there are different types of telemedicine clinic. One is at the rural area, second is at the PHC, second is at the city level. So our focus, since we are working on the ground in the village level, so what is our goal? Like as Sambit has, I mean, I can give so many examples. There's a lady who walks in with a blood sugar of 521. There's a gentleman who walks into the office with a blood pressure of 240. That is, of course, disability are all important. I'm not saying, every person has to have we have to provide them, high quality care for every people. But our main focus at this particular point should be prevention of non-communicable diseases. And so what we are doing is we are entering all the data of all the villages. The question was raised. So we are entering all the children data also, school children, and we'll be following them longitudinally also. So that's the reason electronic health records is the key. Then if you come to the primary healthcare center, so in rural areas, we don't need qualified doctors because they're not available. Again, the same problem. You can't send a nurse and get all this stuff. And ASHA worker cannot be overburdened. So we're looking at the broad picture. ASHA worker is already working her head off. And then Anganwadi teacher, also she is working her head off. She's given so much of responsibilities. Putting any responsibility system will break. Even that system will break. So I think probably as I shown in my picture, that girl is not even intermediate passed and she's able to do things. Yes. So we are working on that criteria where a 10th class electronic health record should be so beautiful that you click. That's it. And then next question should follow. A person who is reading that. So instead of the doctor taking the history, she is replacing the questions. So she is entering the data. That's all. So we do not need, so low cost also. Till once the system works, like suppose if our digital village really becomes good, like where digital education, digital jobs, and digital healthcare is there, then the physicians will go there. And then the doctors will automatically want to go there and away from this rural population. So in other words, what I'm saying is, again, it depends upon the level of practice. What is the focus? So as Dr. Ganapati has mentioned, the moment you get a suspicion where you cannot handle, this is a primary care and preventive care we are doing. This is not in rural areas, in the village itself. Now we're not talking about the primary centers. any particular thing, the physician is seeing on the other side and tells her no. Yeah, later on in the future, definitely, as we were talking about, I'm so happy, I'm so thankful to Dr. Ganapati. She has shared these experiences. What I was thinking is a possibility and a reality, and I showed in the picture. So we have to work in that direction. So again, primary care, very, very important in rural areas. At PHC, the cases are referred, there the disability centers should be set up. I'm sorry, hope I answered your question. It depends upon the level what you want to do. Disability cannot be evolved in a village center, village telemedicine center. It has to go up to the patient has to be immediately referred to the primary care center at the mandal level. He has to go there. And if the primary healthcare center cannot handle it, then it has to go to the district level.
Thank you so much, Dr. Reddy, for answering the question. But I would also like to hear from our participants who have joined today. Many of them are from medical profession themselves and are also telemedicine consultants running telemedicine centers in the states. So I would really like to hear their inputs and their, what their insights are on this topic of bringing telemedicine to rural areas for healthcare access. So can we have, okay, I can see Akanksha's hand raised. Please unmute yourself and talk. Akanksha Sharma.
Hello.
Yes, you're
Actually, my question is about finger stick. Sir has mentioned earlier about finger stick for HB levels or sugar levels. We can check it, but I just want to know that is this method is accurate?
Yes, they're tested.
I don't think so because I myself get checked with this HB test I have done, but I got 8 grams of HB. And then I got the institutional checkup and then I got 11.2. So I don't know which one is accurate.
Oh, and I'm so happy you raised this question. I think we need to study that also. So there are different hemoglobin meters also. Would you mind sending us what machine, what we're using, if it corresponds to the same thing? And really, I'm so happy you raised this question. So now it raises another question and we need to check that. And that's the reason why we want to work with IIT Hyderabad. So we have started that thing. So where they can easily check that.
Okay.
Can I just add a comment?
Yes, sir, please.
We use point of care diagnostics for the last 4 years, including HbA1c. The Apollo Diagnostics is a huge setup, and they're obsessed with quality control. Okay, so in the experience, when they do hundreds of thousands of HbA1c per day, probably. So they are doing all this, and they have not had any problems, including point of care diagnostics. But then there are so many variables, like the way it is stored, the temperature in which it is done. One swallow does not make a summer. From a statistical point of view, if you take 10,000 HbA1c read in a POCD device and compare it with 10,000 NABH accredited laboratory, the statistical difference is within acceptable, permissible limits. Having said that, for one particular individual, maybe there was a variation, but I would like to reiterate that the future is POCD. And I believe that in my lifetime, the huge laboratories we know today are all going to get into the Jurassic Park.
So, Dr. Ganapati, if I can ask you a question, sir, is your labs, is it finger sticks or it's a lab?
No. Labs use a regular. I'm talking of telemedicine units. We have 230 telemedicine units. So there we use a POCD, point of care device, for HbA1c.
Okay,
and
so that is
compared with the labs.
Is a point of care device means how? What is the process?
Okay, point of care device. You don't require a paramedic even. Anybody, just like a glucometer, you take 0.1 ml of blood, put it into different strips. We can do 33 tests, including troponin 1, troponin 2, including electrolytes, including urea, creatinine, bilirubin, liver function tests, renal function tests. They are expensive, but every single test can be done with a drop of blood, which is what we do in the Himachal Pradesh at 14,000 feet height.
I'm so happy I met you, sir. So because I need that.
We are doing this for the last 5 years.
So that'll be great. So we don't have to reinvent the wheel. So probably that lady has got a very viable question.
Yes.
It has been checked or not. So
Can we also hear from Sambit and then from Dr. Divya? I can see both hands raised, but from panelist first and Dr. Divya.
Yeah, so I guess Dr. Ganapati covered that point, but I want to cite a personal experience of a couple of months back about this point of Akanksha. Point has been covered well, but so my father used to reside in a small town in Talcher. I come from a biochemistry background, by the way, so I will make the connection like that. So I work in Manipal, and I am well aware of trop T, trop I, and my father had a chest pain, and the small town did not have an auto analyzer where the trop T, trop I could be estimated. Very swiftly, a diagnostic center, it's a very small one, which is very close to my house. And in a few hours' time, they send me a photograph of a strip, the card test. And me, my colleagues here were really astonished because we had never seen a card test for Tropti. For us, the turnaround time is very small here in the lab. We get it through the Cobas 600 auto analyzer. That's standard for us. So again, going back to what was discussed, what both the seniors here have mentioned, context matters. So at that point of time, that card test suffices to give a broad overview, and that is why everything is contextual. And like Professor Ganapati rightly said, this has to come from an evidence point of view. But POCT is, going to stay. Standardization is a major issue there which needs to come in. We have to standardize, but that is the way to go further.
Dr. Divya, can we also hear your point, please? Dr. Divya.
Hello, nice to hear all the discussions, and also I'm very happy to hear the huge experience of Dr. Ganapati, and also uh, uh, from the activities of the Swasodhan Trust. Anyway, going to I just want to make the same point. Obvi- of course, it is contextualization, but as far as many of the treatment protocols are concerned, there are many written or very obvious protocols that are in place, which has some of these points as which can be only dealt physically. But so I just feel that there is a huge academic activity which is pending from each and every specialty in identifying which are the clearly deliverable subset of, or what is the stage of disease, or stage in the management of treatment, where there is nothing other than telemedicine is needed without even any added device. I understand there are a lot of digital equipments which are coming up which can be linked easily, but without even anything, like even with the eSanjeevani telemedicine platform, or even any telemedicine platform, these are the things which should be consulted with. There is no need of any travel required. That's a huge area which can be worked out. That is one point I wanted to make. Then there is, as far as this, many of these platforms which clearly follows the protocol. So nowadays, many of these doctors, including myself, we in this hurry we skips many steps. So it is very much helpful in practicing ethically. We won't forget these steps of asking something, because there is a thing that is in the what is that screen which makes us remember asking some questions. Then again, there are good practices, like already Ganapati sir has told us regarding the elderly care, what he did after a neurosurgery. And in Kerala, we actually do this. All of our local self governments have this palliative care project, where a palliative care nurse is going to each and every house. So palliative care nurses are these patients are, many of them have never met a doctor for last few years, 5 to 10 years they haven't met a doctor. So this is a very good way we could actually collaborate, we could actually deliver something very in a very good way to this palliative care patient. And now in we introduce the same service to jails also. The jails are also utilizing this during the reopening of schools. We already opened it for schools also, and definitely there is a 24-hour COVID-19 OPD also. Thanks for all the insights. This is what I wanted to
Thank you, Dr. Divya. There is one last question before we conclude. There is not much time left. We have a question from Telemedicine Consultation NHM Mumbai. I don't know the participant's name, unfortunately. Is asking, can we use the facility in an offline mode, and then when the internet facility is available, can we register the same case on the telemedicine application? Is there any guidelines available?
Yeah, can I respond to that?
Yes, please.
The telemedicine guidelines makes it very, very, very clear that everything is contextual, should be done in the interests of the patient. You need not be afraid at all that you are violating the guideline. The very word guideline means it's a guideline. It's not written in stone. So everything is contextual. You can certainly, if you, based on the clinical condition of the patient, the socio-economic considerations, where you are placed, what is your background, what facilities you have available, etc., 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 you certainly have the right to give a remote consultation in an offline mode. And when internet facility is available, you can register the same for a telemedicine application, provided the circumstances justify that particular decision on that day, at that time, in that situation. So it's entirely the clinical scenario. You have every right to do whatever you think. Please don't get worried. I'm telling you this with such confidence because some of us in the TSI made all these guidelines, gave it to the government. We have discussed it at the highest level, and the government has told us again and again, it depends on the individual situation. So please do not worry at all about the telemedicine application. And as of a few weeks ago, I can assure you, from the last 22 years, we have not had a single patient complaint which has gone to a consumer protection forum, excepting for one case which was misquoted in the media thoroughly by the Bombay High Court. We have not had a single instance. So most people who use telemedicine are unnecessarily getting worried about it. So long as you do what is in the best interest of the patient at that time, it doesn't matter at all, even if you did not strictly follow the 6-size font sub note written at the bottom of the page. So forget about it. Do what you think is in the interest of the patient.
Thank you so much, Dr. Ganapati. Dr. Reddy, can I have some input from you on this?
I'm so happy. I don't have any experience, and it's so nice Dr. Ganapati has summarized it.
Right. Dr. Samit.
I guess one of the closing remarks I would like to make, drawing from what Dr. Ganapati actually said, it's very important that the competencies of telemedicine get into medical education. I think that will be a way forward, and each specialty must, the societies of each subspecialties must come out with their set of guidelines. All these should feed into, because otherwise it's too heterogeneous. All this should feed into ultimately making doctors who are competent in handling telemedicine.
Thank you so much, Dr. Samit. And with that note, I'll have to conclude the session today. We are well past our time, and the workshop, of course, will continue again tomorrow. We have another session at 9 a.m. tomorrow from Dr. Gokula will be joining again from the US. So I request all our participants to join in time so that we don't keep our panelists, awake. It's late night there. So please join before 9 a.m. tomorrow. And thank you. thank you for joining here today and engaging with us and staying with us throughout the program. I also thank Dr. Ganapati, Dr. Reddy, and Dr. Sambit for joining the panel, staying after the panel, and interacting with our participants as well. And I hope that we will be able to have you in the future as well and continue to talk to you when we draft these workshop outcome documents for our own ministry and find out where we can coordinate with the health department from RD to kind of take telemedicine beyond the urban areas and to the rural areas as well. So with that note, let us conclude today's program, and we will again meet tomorrow at 9 a.m. using the same link that has been provided to you. I would again remind our participants that we have shared a registration link to the WhatsApp group. I'll also share it in the email. Please use that, register yourself so that you can, register your feedback as well. Thank you very much and a very good afternoon to you. See you tomorrow again. Thank you.
Namaste. Namaste.
Namaste.